Why we have to have your video on. So folks can then stop. Mute and then have your video on.
All right, we good? Welcome, everyone. Before we officially call the meeting to order, let me take this opportunity to hand the meeting over to Bob.
Good afternoon, everyone, or good morning, depending on where you are in our country. Next slide, please. As many of you know, our Deputy Director, Dr. David Myers, recently passed away. And David fought bravely against brain cancer, and he was extraordinarily open about his journey through the healthcare system and his experience with brain cancer. I'd really like to honor his contributions to AHRQ with a moment of silence as we begin our NAC meeting. So if you'll join me, I would appreciate. Thank you. And as David and I discovered when I first started, we often closed our messages to people with the same phrase, be well. And I know that he would wish you to be well. Edmundo?
Thank you. It's interesting, as in that moment of silence, I think David would appreciate, I thought of it as a moment of contemplation, right? And contemplating many things in that time. So at this point, I'm going to officially call the meeting to order and welcome all of our NAC members, guests, ex officio, all folks to the meeting today. Thanks for being here, and travel has been challenging, so thanks for those who could make it in person, and appreciate those who are here virtually as well. So since we're doing a hybrid meeting, there's kind of a little bit of a logistics here. Okay, thanks. Some logistics on the hybrid meeting approach, right? So all NAC members should use the computers, your Zoom's raised hand function to comment and get in line. I usually can kind of see based on when those hands get raised. And then it's just a reminder for everyone that the event's being recorded. It's going to be posted on the website, on our website. Closed captioning is available for the meeting. There should be an icon at the bottom of the screen for closed captioning. So we're already there. So let's jump into the overview for the day, the agenda. So we're doing the first bullet now, and we'll jump right into Bob's director's highlights. We're going to talk a bit about the aging initiatives. We'll talk about consumer experience measurement. We'll have some public comment time, and then we'll wrap up at the end. So that's the flow for the day. Let's go to the next slide. I think we're going to talk about some more logistics on the meeting itself. So we're gonna try a new approach here in terms of public comment, and so on the second bullet point, we'll still have a verbal public comment option, right? So that's just, the email address is there. Subject line should be public comment no later than 1 p.m. Eastern. Send that email to request time for public comment. Comments going to be limited to 3 minutes each or less. So that's our standard public comment. We're going to add in this time, when this hybrid meeting approach, an opportunity to comment through what we're calling our real-time post. So members of the public can send an email to the same email address, National Advisory Council at arc.hhs.gov. Subject line should be real-time post. And then that we'll be able to take that comment during the conversation, right? So that's a new feature that we're adding in. So a little bit more real-time interaction with the public. Please note with any of these comments, either the public comment verbal as well as the real-time post comments, please be respectful in their comments. Ridicule, obscene, or profane language or personal attacks will not be accepted as public comment. And for both real-time and the public comments, we ask that you be brief, to the point, preferably addressing issues that are actually on the meeting agenda and topics that we're discussing today. So thank you. Let's pop into our next slide. So we're gonna welcome our new members. What we'll do is we'll welcome new members. Briefly talk about yourselves, where you're from, and give a little bit of introduction for each of our 5 new members here, and then all of our current members. We're going to do kind of name, rank, serial number type of intro, so everyone knows who you are as we go around we'll go around the room as well. Let's start with a member who's not physically here, because it's always hard when you're on Zoom. So David Ash, let's start with the intro with you.
Hi, I'm David Ash. I'm delighted to be here, or sorry, not be here, since I couldn't make it into the meeting, but very happy to join the NAC, and I see many people who I know. For those who I don't know, I'm an internist and a professor at the University of Pennsylvania in the School of Medicine and the Wharton School. And I'm a health services researcher, and I've had a variety of roles at Penn. And as I said, really delighted to be here.
Thanks, David. I'll just go through the list. Let's go to Thomas next.
Hi, I'm Tom Buckmuller. I'm a health economist from the University of Michigan, Ross School of Business, and longtime friend and co-author of some AHRQ economists.
Awesome, thank you. Al.
Good morning, everyone. Al Carter. I am the Executive Director of the National Association of Boards of Pharmacy. I am a pharmacist by trade. I'm delighted to be here and be one of the only pharmacists on as a NAC member, and looking forward to engaging and participating in comments going forward.
Thanks, Al. Cincy.
Is it on?
Yep, that's
Okay,
on.
sorry. I'm Cincy Nandescancio. I am the Vice President for Health Justice at the National Partnership for Women and Families. It's a national health and economic justice policy advocacy organization. And I am very excited to be here, both as a representative of national nonprofits and patient advocacy, and also in my own experiences as a woman who barely made it out alive from childbirth, and have multiple chronic conditions, as well as my son. So I try to bring both sides of my life into these conversations.
Thanks, Cincy. Liz.
Hi, my name is Liz Mord, and I'm a practicing general internal medicine primary care doctor at Mass General Hospital in Boston. And in May, I stepped down after 10 years of being the Senior Vice President of Quality and Safety at Mass General. It's a privilege to be here. I'm really looking forward to being a member of this committee, and looking forward to contribute. Thank you.
Thanks, Liz. I think, yep, that's our group. So let's go and do quick intros of our current members. I'm going to start actually to my right. So Andy, start with you.
Hi, I'm Andy Auerbach, a hospitalist at UCSF and a longtime AHRQ recipient of funding, as well as a less long member of this committee.
Thanks, Andy. Come on.
Hello, everyone. My name is Komal Bajaj. I'm Chief Quality Officer for New York City Health and Hospitals Jacobi NCB and a professor of OBGYN at Albert Einstein College of Medicine.
Thank you, Kathy.
Sorry. Hi, Kathy Ivory. I'm Associate Nurse Executive for Vanderbilt University Medical Center in Nashville, Tennessee, registered nurse, OB background, informatics background, and a health services researcher.
Gina.
Hi, good afternoon, everyone. Good morning. Gina Reyes. I'm the Director for Clinical Transformation and Quality for Horizon Blue Cross Blue Shield of New Jersey. I am a registered nurse by training and happy to be here with you all.
Thank you. David Atkins.
Hi, David Atkins. I'm the Director of Health Services Research at the VA and former AHRQ employee.
Thank you. David Schmitz.
Hi, David Schmitz. I'm a practicing family physician and researcher focused on rural health. I am a professor and department chair at the University of North Dakota.
Thanks, David. Krista.
Krista Hughes. I'm the founder and CEO of Hughes Advocacy, and I'm a board certified patient advocate.
Thanks, Krista.
And Neil Goldfarb, president of the Greater Philadelphia Business Coalition on Health and Employer Coalition in the Philadelphia region.
Thanks, Neil. Henry.
Good morning, everyone. Henry Ting, cardiologist and Senior Vice President, Chief Health and Wellness Officer at Delta Airlines.
Thanks, Henry. All right, I'm gonna scope out my my Zoom folks. I see Mireille.
Hi, I'm Mireille Jacobson. I am a health economist and associate professor at the Leonard Davis School of Gerontology at the University of Southern California and the Schaefer Center for Health Policy and Economics. Thanks.
You. I think I see Joe Draco.
Good morning. Yes, good morning. Good morning. I'm Joey Drika Brown Spates. I'm professor and chair of family medicine, rural health at FSU College of Medicine, and I'm a family physician. Nice to be here.
Thank you for being here. You said who else was on? Oh, got it. Okay. Caroline. Yeah, she's on. Yep.
Good morning, everyone, and welcome to our new members. My name is Caroline Carney. I am the Chief Medical Officer and President of Magellan Health. I am a board certified internist, psychiatrist, and a recovering and still sometimes academic. I also do work in an FQHC. Nice to meet you all.
Thank you. I think I have members. I want to go to ex officio members now. Sherry Ling's on, I think.
Indeed, I am. And good day, Sherry Ling, Deputy Chief Medical Officer representing the Centers for Medicare and Medicaid Services. I am a geriatrician and internist and rheumatologist and volunteer dementia care provider serving veterans in Baltimore. Thank you.
Great. And the pictures are moving around here. Give me a sec. Oh, Michael Lauer. There you are.
Hi, good morning. I'm Mike Lauer. I'm the NIH representative. I'm the Deputy Director for Extramural Research at NIH, and by background, I'm a cardiologist.
Thank you all. Is there anyone that I missed? Great. All right. So quick, before we jump into our director's highlights, again, quick kind of Zoom logistics here. So remember, you can change attendees. You can change your video settings so you see all the members and speakers by going into the settings. Click into the settings. But before we get into the director's highlights, our actual first order of business is for approval of the minutes from the March 6th meeting. The assumption that you all have had a chance to review those minutes. Are there any changes or edits that we're requesting to those minutes? Seeing none, do I hear a motion to approve? So moved. Do I hear a second? And a second. It's been moved and seconded. Any objections to approval of the minutes? Seeing none, those minutes are approved. Let's turn the meeting over to Bob for director's highlights.
Thanks very much. Thanks very much. And welcome to our new NAC members. It's really great to have a full contingent of the National Advisory Council. And I really look forward to the advice that you have to offer the agency as we really figure out how to pivot the agency to move the agenda forward. And the agenda, as central, is how do we improve healthcare in the United States? It's clear that the performance of the US healthcare systems, and I always like to stress that because we have no single system, has been relatively poor. And that's being generous from my perspective. And our annual report to Congress that talks about the quality of care and disparities that we see racially and ethnically in our country hasn't changed over the last 22 years. And so I'm hoping that with your help and advice, we can change that message, that we in fact are making progress, that we're pivoting to serve the needs of the American people. May I have the next slide, please? In order to do that, I know that many of you have heard that the federal government is rethinking our budgetary situation. And so as you'll remember, in 2023, which is our current fiscal year, in every year we're working actually on 3 budgets at the same time. We were allotted $373.5 million. In addition to that, we get about $100 million from the Patient-Centered Outcomes Research Trust Fund, which is money that's collected from health insurance premiums around the country, and then shared between the PCORI, which is the institute which funds research, ASPE, which gets a small share of those funds for data systems in the Department of Health and Human Services, and then our share, which comes to AHRQ for 2 purposes: for dissemination and implementation of research findings, as I like to say, turning that evidence into actionable knowledge, and then helping health systems and clinical providers improve care that's provided at the bedside, in the clinic, at the home, increasingly in different sources. We're now developing we've developed our 24 budget and redeveloped our 24 budget. So we're in that process now. And we're also preparing for our 25 budget presentation to the department. So it's a crazy period, but thanks to Lucy, who I think you may know, who's in the back row there. She's our chief budget officer and budget wizard, helps me figure out how we can actually move our agendas forward, regardless of where we are in this process. Next slide, please. As you know, there was an act put forward that will affect how we think about our budgets going forward. And right now, my best case scenario is that we see our funding level remain at the 2023 level, although others are expecting potentially a reduced budget going forward. If we don't get budget bills in place, we can expect a 1% across the board spending cut that would be triggered January 1, but wouldn't go into effect until April, giving Congress additional time to sort of fix the appropriations bills. So that's the context within which the agency is operating. And as you know, we have discussed a number of initiatives here at the council that were included in our budget requests. And needless to say, we're going to figure out a way to actually move forward with those initiatives. Why? Because the American people need to see their health care improved. And so we'll figure out some mechanism by which we can take your advice and still move the agenda forward. I want to assure you that the senior staff is dedicated to that, and many of them are around the room. I hope you'll have a chance to chat with them either during our breaks or after the meeting, because they look forward to your advice and counsel. Next slide, please. Well, we actually have 2 demographic major shifts going on right now in the United States. The first is one that was dramatically seen during the course of the pandemic, and that is a dramatic drop in the average life expectancy. Today, we can expect to live at birth, those children who are born today, 76.5 years. That has declined since 2014, when life expectancy on average was at its peak. That means that we've lost basically a 26-year progress in life expectancy. That means it's affecting that bottom rung of these charts that I'm just showing you here. This is really a health equity issue, because those lower rungs are a much more diverse representation of the US population. And we've seen during the course of the pandemic, a 6.5-year drop in the American Indian life expectancy, the greatest drop that we've seen in ages. That life expectancy of 65.2 years was what the average life expectancy in the United States was in 1944. We just cannot continue this. We saw Hispanic life expectancy during the pandemic drop 4.2 years. We saw African American life expectancy drop 4 years. Why did that happen? In large part, it was because they make up a large share of essential workers that in the States and in an early part of the pandemic were asked to take the risks so that many of us could work at home, have our food delivered, and continue to work. What it also represents, though, is some other catastrophes that have been going on in our country. A huge rise in drug overdoses. Among young and middle-aged people, we've seen a 900% increase in drug overdoses. We've had a long-standing problem that people have often forgot about because we talk about opioids and the opioid epidemic, and that is the long-standing issue of alcohol misuse. And among these age groups, young and the middle-aged population, we've seen 175% increase in alcohol-related deaths. These are all preventable, and they're preventable by healthcare. And so as we look at how we deal with preventable healthcare, pardon me, I got a little emotional here. When we get, when we talk about preventable deaths, a lot of it is what we can do with the healthcare system in pivoting to wellness and prevention, recognizing that for many diseases, while our biomedical advances have been great over the last 25, 30 years, our advances in actual treatment have lagged far behind. And so much of what we need to focus on is how we create a wellness-oriented care delivery system rather than a focus on what used to be a cure system. That's my own perspective. And yet, as this chart shows you, we continue to have one of the most rapidly aging populations in the world. And so the demands on our healthcare delivery systems are coming from two different kinds of demographic issues. 3 years ago, the World Health Organization declared this the decade of healthy aging. They didn't mean that we should be thinking or doing healthy aging. This was a year for planning, for pivoting our systems, both healthcare and service delivery systems, to thinking about shifts in populations that are going on across the world, similar to ours in the United States. Healthcare systems throughout the world are not prepared. Ours is very not well prepared to deal with this demographic demand. In New Mexico, I think we were kind of at the tip of the iceberg. Our patients walked into clinics usually with not one complaint. They walked in with multiple. They had multiple chronic conditions. They had huge social needs that are the result of the inequities that exist upstream in what we call the social determinants of health, or in healthcare, the social drivers of healthcare. And hopefully we'll be able to talk about that and look at how we're thinking about that at AHRQ. And I look forward to your recommendations for how we should further think about how we move and pivot local healthcare systems to respond to the needs of an aging population in all of our communities. Next slide, please. There's been a huge shift in the way we think about aging over the years. In the 1970s, as you'll note, there was this real focus on ageism. And I think that's part of what we need to deal with in our society, is to get away from the ageism. On the other hand, we have the other situation just a little over 18 years later. It was talked about as, in our senior years, that's our fun years. And today, Oprah Winfrey, if you look at her latest publication, is talking about the 90s being the new 40s. So you know, I think there are lots of people who are recognizing that as people age, particularly that large bar that I showed you at the top, many of those folks are in fact staying very, very active. And part of these years of healthy aging is to recognize that these individuals still have much to contribute to our society, knowledge, experience, and other activities, rather than in the 1970s when we thought, well, they're really no longer productive. Many of the people that I've talked to recently who are in their 80s, who've retired finally, still want to do things, still want to contribute to our communities and to our society, and yet we don't have good mechanisms. Maybe there's an opportunity in healthcare for them. They actually do this journey through healthcare and have great experience there. Maybe they're a resource that we should think about. Next slide, please. First of all, I want to thank Karen Ginsberg for her leadership of CAPS. CAPS has been really a cornerstone for AHRQ's contribution to understanding the patient experience through healthcare. And as we talk today, I'd like us to remember that health services research started with a real focus on what it is the customer needed and wanted. The customer perspective was at the center of defining our research and our research agendas, and the findings were used to improve, or thought we could improve, people's journey through healthcare. It's been a long time since we've talked about how we do this. There have been a lot of advances over the last 20 years in the way different other service industries look at the customer experience and use that information for providing better services, or better delivery of services, or better models of services. And hopefully you can get us and to begin that discussion as we think about the future of our work in understanding patient safety and advancing CAPS and perhaps other kinds of approaches that make sense in the 21st, 22nd, and as many of you know, I'm looking at the 24th century. I was at a recent meeting at DARPA on Monday, where it's real clear diagnostic possibilities using the episome is possible. We can get signals of exposures. We can get signals of different disease states. And on the military side, they're looking at handheld scanners for trying to understand whether or not people have been involved in dealing with explosives and other kinds of things. So those kinds of new technologies, those revolutionary diagnostic technologies, are close at hand. It's no longer the potential that, you know, Star Trek, they'll put that little thing on your hand. We might be getting there pretty soon. And we've got to figure out as an agency how we understand that evidence and turn that into actionable knowledge that healthcare providers can in fact use. So, but they can only use it if that's what the customers want and need. So I look forward to our discussion today about how we move this agenda forward, how we rethink or not what we are doing. Maybe we're doing everything right. And we also need to hear that. So I thank you for being willing to take on these tough discussions, and I'll turn it back over to our chair.
Thank you. Thanks, Bob. So we have a few minutes for questions from NAC members if you want to ask about Star Trek tricorders or anything else. Go ahead and hit raise hand in the Zoom, and I'll take it. I'll take you all by as I see them.
Well, before there's a question, I also want to just put in a plug. Next year is our 35th anniversary. Our agency was first established in 1989 under a different name, but it's still the same agency. So I want to get you thinking about how should we celebrate that 35th year? What should we be doing? So if you have ideas informally about what we should do and think about celebrating that 35th anniversary, by all means, please send me notes.
Any questions on the director's highlights? All right. Oh, Neil, see you. Yep.
Bob, just going back to the comments about the budget, what is there a role for us as NAC members in encouraging our legislators to support continued or expanded funding for this critical mission?
Well, as public citizens, you have all the opportunities in the world to communicate with your legislators. And as good health services researchers, I hope you're in good contact with your legislators, both at the state and federal levels on a variety of issues, because that's the cornerstone and the difference between a health services researcher and someone who's doing a more academic type of non-applied research.
Other questions? Okay, seeing none, let's jump over to Arlene Bierman, she's our Chief Strategy Officer for AHRQ. And we're gonna jump right into this this conversation on aging initiatives. Arlene, you ready?
Yeah, hi.
Let's do it.
Welcome, everybody. Welcome all the new NAC members. It's great to be here in person. And I really want to make this a dialogue. I really want to hear from you. I think the answers are around the table. So I think this is just following up on what Dr. Valdez had said. Sorry, little technical movement here. So the US population is aging, but we all know that our health system is woefully unprepared, and just the numbers against the figure that the population age 65 and older increased from 39.6 million in 2009 to 54.1 million in 2019, which was a 36% increase, and it's going to be 94.7 million by 2060. We know that life expectancy and active life expectancy, the years lived without disability, are declining, and the inequities on these measures are associated with race, ethnicity, and socioeconomic position are widening. So aging is actually a health equity issue as well. Low income and minority individuals age faster in something that's called weathering. But there's a lot of nihilism around aging, and much of the morbidity and mortality is preventable. So the question is what can we do to really improve the health, well-being, and functional? It doesn't matter how well connected app. As people on the table. I think it really resonates. So I got permission actually from one of my to tell the story of her dad. When I emailed her, asked her, she sent me one. And so he's a 7-year-old, independent living France, but actually independent, now. And it really extended. Standard practice. I guess somebody could ask. Okay, better now. I just like, of course, it's going to get to you. And you can very developing the change. And so he was discharged to do that. And although the medical records stated like we have to fix it, and we needed, so we have to saying that he stated and
What's on Zoom computer meeting?
So we hear you guys very softly. It sounds like the microphones in the room stop projecting the sound.
Yep. You hear me now?
No.
Video.
A minute. Something's wrong with the cable. Right, because we know that. Can you hear me now?
Yes.
Okay, so I'm not going to repeat everything I said, but just briefly, for those online, you could read the slide and just, the demographic challenge around aging is enormous. It's a huge equity issue. And there's a lot that we can do about it that we're not really paying enough urgent attention to. I started telling the story of, one of my in-laws' dad, who was 89, frail, admitted for a heart attack, got a stent, discharged to rehab, clearly deconditioned after a week on bed rest, and was forcibly really bullied, discharged from rehab after a week because the algorithm, he's a member, it'll go unnamed, of one of the major Medicare Advantage plans in the country. And it was even documented in the chart by the rehab attending that he was not ready to go home. And, I was thinking about it too, that I'm actually doing some work on algorithmic bias and how this, can actually introduce bias, because who can argue with the algorithms and who has the resources? So it might be a new source of inequities. Anyway, so they sent him home. Not surprisingly, he became dehydrated. He developed pneumonia and renal failure. And he was readmitted exactly a week after being discharged. He was hospitalized for 10 days, sent to rehab again. And at this time, he was again discharged prematurely. He could barely sit up and definitely could not stand by himself, and went home with his older, frailer wife. So, it's interesting. I'm just going to read a quote that was sent to me. So they're now on their third appeal. And it says, "We are still in fighting the insurance company." He's on dialysis now too, also 3 times a week. Totally all preventable and really tragic. It took an army of people to fight for my dad. And we are the lucky educated ones with resources. It was hell. I can't imagine what other families who didn't have the resources must have to go through. We have to fix this. But I'm going to tell a better story. So the system is still broken, still doesn't work. Well, I was recently in Seattle for Academy Health, and my son wanted me to see one of his good friend's parents to give them advice on navigating the health system. So the story was they had just moved up within the last couple of weeks from Southern California to Seattle to an assisted living. And her grandmother had been admitted to the hospital, did well, sent home, ready to go home, given a discharge plan, long list of things to do with no help, all these appointments, follow-ups, everything she needed. And her doctors are all in California. They had no idea what to do. So I basically, gave them a talk on navigating the system, who to call at the hospital, how to do this. And actually, it's a happy story. She got a good appointment with a neurologist. She got physical therapy, occupational therapy. She got in touch with her primary care doctor in California, who's going to manage her virtually until she gets a primary care geriatrician in the Northwest. So, but it's just an example of how the system doesn't really work for anybody. No, So, okay. Now, so just to reemphasize, so the healthcare in the US falls short of achieving objectives in improving individual and population health. It's ill-designed to foster active aging, so it's disease-focused rather than person-centered. Everybody at AHRQ knows all of this. It's focused on illness rather than wellness. We know that quality is suboptimal, just gave examples. Care is fragmented, difficult to navigate, and burdensome. And that people say, well, we don't have money to do this. Medicare is in trouble, but there's so much waste in the system. Kind of Will Schreink's classic paper in JAMA a few years ago, that we spend, between $760 billion and $935 billion on waste, 25% of the total healthcare spending. So can we work on reallocating that to give people the services they need? The other thing is that there's also been, I think there's considerable return on investment, and we can make this case. And, Dr. Valdez alluded to this. There's two sides to the aging, right? So there's people who are going to be high cost, high needs, need lots of services, lots of support, and we have to give those to those. But also it's an added value to society. All these people are aging with a lot to contribute. And so there was an economic analysis published in Nature aging in 2021, that if you could delay disability by a year in the aging population, it's worth $38 trillion US over 1 year and 367 trillion over 10 years. So maybe we could start making the case on return on investment for investing on improving aging. And we all know about clinician burnout and how it's been exacerbated. And I think one of the causes is that people can't, I just feel for the rehab doc who was saying this patient needs to stay and they're discharged anyway. So it's not advancing. Oh, there. So many of you in your hospitals might be familiar with the, John F. Hartford, the age-friendly hospitals. It's gotten a lot of traction. That's making a difference. But I just want to let you know, it's part of a larger age-friendly ecosystem. And I encourage people to, read the reference by Terry Fulmer on this page. But it started in 2006 with the WHO with age-friendly cities. There's actually a real movement now with the also with the Hartford Foundation and Trust for America Health on age-friendly public health. And they're working with several states across the country to implement age-friendly public health as a model that could be expanded. But there's also, age-friendly universities, employees, communities. So we need to bring all this together, because if we're really talking about population health, we need to, the healthcare is clearly, a key part of this, but we need to know how to interface with the whole ecosystem. Oh, this one. So when I talk about aging, I feel like it's the elephant in the room. Sometimes even if I stand in the middle of the room, no one acknowledges me. And as I was preparing for our aging roundtable, which you'll be getting the summary of later today or tomorrow, it occurred to me that there's so much exciting work going on. A lot of you might be aware of, innovations, frontline things, also in multiple sectors, but we don't coordinate and we don't know what each other is doing. So I started to think maybe we're really the blind men and women in the elephant, like we're all doing our little piece, but we're not connecting the dots. So this, AHRQ is really focused on the learning healthcare system. And actually, Victor Montori, who is a former NAC member, worked with us on this framework, which we call the care and learn model, because we do need the learning health system and we need all the, data-driven, evidence synthesis, implementation generation. But we can't forget that the primary function of the health system is to care. And so we put together this care and learn model to integrate the caring function together with the, data-driven learning health system model. We had a lot of great discussion. We brought people from multiple sectors to our roundtable, and there was a big debate on whether it was like, well, we needed policies to support, more aging well, or whether it's payment. And clearly you need both. But then clearly what the discussion focused on is that it really is culture change. Which is really hard, even if you had the right policies and payments. If we don't change the culture, it's not going to work. And also we need the evidence, both for the best, clinical management of people who are complex or have multiple needs, but also the evidence for how to transform care, which is where AHRQ can contribute. And so really the sweet spot is getting all these things aligned, which is really tiny. So, how are we going to get there? I think, the Department of Health and Human Services has a lot of priorities now that are really aligned with improving aging well. So the focus on the social determinants of health, focus on strengthening primary care, integrating behavioral health and primary care. So this is actually a framework that was developed. There's a working group that's a subcommittee of the Department of Social Determinants of Health, where we're really working on how to expand community hubs. And ACL, the Agency for Community Living, is really supporting community hubs. And these are organizations that bring together the community and social services in a community, and in a way that they could integrate easier with the health system. There's, clearly improving outcomes in older people, also involves addressing health-related social needs. And it's hard for health systems to do that. And there's a whole health, social service sector out there that's been doing this forever. So how do we really link with them? And this was in a health affairs forefront, and the link is there if people want more information about the community hubs. I think also there's been a lot of groundwork that we can really build on. There's 3 recent NASM reports that can really inform this agenda and our work. The first one I'm going to mention is the Roadmap for Healthy Longevity. And it's a long report, it's multi-sectoral, so it'll deal with housing, transportation, environment, but there's a really good chapter in there on health systems. So I would encourage people to take a look at that. And what they recommended was we need to shift healthcare systems to focus on healthy longevity. To catalyze actions to be taken include health systems in concert with communities and the people they serve should adopt affordable, accessible, culturally appropriate models. And that government should develop plans for aligning healthcare payment and reimbursement systems. Healthcare systems should measure care outcomes based on patients' goals and preferences. So we'll be talking about measurement later. So the other, this came out a couple of years ago, the NASA report on implementing high quality primary care, and actually AHRQ was a co-sponsor of this, and they really talk about the need to invest, strengthen primary care, and that the provision of whole person, and this is the first time I saw the NASA use this word, they updated the definition of primary care, whole person integrated, accessible, and equitable healthcare by interprofessional teams who are accountable for addressing the majority of an individual's health and wellness needs across settings and through sustained relationships. So there's the relationships and caring again with patients, families, and communities. And the department is going to be releasing its action plan in the next several months on how to strengthen primary care, which is a cross-department effort. But when people thank you. What people don't realize is the only way we're going to take care of an aging population is through primary care with strong linkages to the rest of the system. I don't think people realize that, how critical primary care is to take care of people who are more complex, have multiple chronic conditions and multiple, including social needs. And then this is the most recent report that came out. And I know David Atkins of the VA, this is really sponsored by the VA, the Transforming Healthcare to Create Whole Healthcare. And I think when we talk about aging, that's what we really want. It's whole health. We want people to be as independent, active, engaged in the community for as long as possible. So whole health is physical, behavioral, spiritual, and socioeconomic well-being as defined by individuals, families, and communities. Whole healthcare is an interprofessional team-based approach anchored in trusting longitudinal relationships to promote resilience, prevent disease, and restore health. It aligns with a person's mission, aspiration, and purpose. And of course, whole health care needs to be delivered in the context of a whole health system that really supports that. So AHRQ has had a big focus on multiple chronic conditions. And I think a lot of this work is transferable to our aging, agenda. And what I want to point out here is there's been a lot of focus on the high cost, high needs, high risk patients and how to improve their care. And that's really critical in terms of targeted interventions for those who have complex management issues and at high risk for avoidable adverse events, et cetera. But we haven't focused on prevention, health promotion, and wellness. And the reason we actually do have, we're just getting over the COVID pandemic, hopefully, we don't know what's going to happen, but there's really a syndemic of multiple chronic conditions in this country. And that, the reason we have it is because it's the same common risk factors that are growing in prevalence that cause many, many of the common chronic conditions. So we really need prevention interventions targeted at reducing the prevalence of common chronic disease risk factors with a particular focus on interventions to reduce the likelihood for those at risk. We also need targeted interventions to improve health and reduce the risk of adverse events and complications for those who are at rising risk. And I know a number of health plans are focusing on the rising risk. And so those are people who might have, COPD, diabetes, maybe some heart failure, but they're stable, but they're just one event away from being frail, complex, in that high cost, high needs group. So how do we develop interventions that target risk stratify people and target them appropriately where they are on that continuum? We've also been doing a lot of work in terms of, our research agenda setting, and I'm not going to spend a lot of time on this. I did send out this paper, but to think about the attributes of primary care in the context of what are the attributes needed to improve the health of an aging population. So person and family centeredness, community centeredness, primary care centeredness was a new one that we threw in, that the system really needs to be focused around primary care. We need to advance health equity. There's a huge opportunity for digital health solutions. We need to align payment models, and there's huge workforce needs. And we published in HSR a couple of years ago our research agenda to transform care for people living with multiple chronic conditions. And again, these transfer very well. And I am going to read these because I want you to think about these in terms of the kind of research or what you think AHRQ could be doing to advance some of this work. So we need patient practice, community, and health system level interventions and multi-level interventions to transform care. We need culture change. We talked about that in both practice and training. We need partnerships and policies to be able to address the social determinants of health and address health inequities. But we also need patients, families, caregivers, clinicians, frontline workers, and communities as co-producers of evidence and co-designing these interventions to increase their likelihood of success. And also, we know the current payment models present a barrier to innovation, and we need the evidence on what works in terms of payment models and incentives. And I think we not only need to deliver care differently, we need to do research differently. The RCT is not going to work. These are complex interventions in complex systems and people with complex needs. And there's a lot of advancement, borrowing from complexity science, agile implementation methods, mixed methods. There's a lot we can do to really learn, how to make this work in the system. So we put out, one of the things that came out of the multiple chronic conditions work is that I think the linchpin is having a good integrated patient-centered or person-centered care plan. And we put out an RFI in the Federal Register, and I'm not going to read this, but we wanted information because our sense is that there's a lot of people doing a lot of innovative stuff, but they're not necessarily the people who are publishing it, and not even in the great literature. So we really wanted to understand what was going on out there. What can we learn from the work out there? What are the barriers and how are people overcoming them? We got a robust response. We got 55 responses from very, very different perspectives: health systems, NGOs, patients, clinicians. And it did confirm what we assumed, was that, there is a lot of good work out there, and what can AHRQ do to catalyze this and bring it together and create some shared learnings. And we're in the process, by the end of the summer, we're doing a qualitative analysis, of the hundreds of pages of response and have some themes and lessons learned. And we are, exploring how we could inform, how we could create some stakeholder and, clinical and research communities to advance care planning as one way to tackle this. I mentioned, I think digital health, if used appropriately, there's so many ways that it could support the care of older people. And I'm just going to mention, one initiative. This is something that I'm leading at AHRQ in partnership with NIDDK, but we're developing an interoperable shared electronic care plan. So it's a Smart on Fire app. We're sponsored by HL7, so we're creating international standards for care plans. Everything is open source in the public domain, so we encourage people to build on our work. But the idea is you could aggregate data from multiple different health systems. If you're an integrated health system, you have all your data there, but most people see multiple providers across systems with different EHRs that don't talk to each other. So it's really important to be able to pull this together, both to provide better care, but also to avoid, the adverse consequences of competing care plans. The other unique thing about our care plan is that we're collecting social needs. We're collecting patient goals and clinician goals for the patient. So you could display them on the same page and start a conversation. How do we make a plan that helps, achieve both? And we're also have the capacity to include patient-reported outcomes. So we have actually a clinician-facing, patient-facing, and caregiver-facing apps. We're pilot testing it at OHSU now. And so, we have like the PHQ-2, the Promise 29, a caregiver burden, we have Prepare, but people could add whatever, problems. It's very easy to add whatever patient reported outcome you want to that. So I mentioned our roundtable. I'm not going to spend time talking about this. You'll be getting the summary of this roundtable. And if people have ideas, really reach out, email me and Bob. We want to hear from you of how we could build on, some of our learnings from that. We've also, some of the opportunities identified at the roundtable was a need to develop a truly person-centered care system. This is, things that I've already alluded to, generated evidence on what works to transform care, and how do we really broaden impact? Like, how do we take what we learn and really scale and spread it so it becomes part of routine care, not in just the centers of excellence? And, really, what are the opportunities to focus on promising approaches to health system transformation? We've also been reaching out very broadly. I did a listening session at the American Geriatric Society that was incredibly well attended, where we got all kinds of input from people on what they're doing and what we might do. We had a recent panel at Academy Health called Averting the Impending Storm, Health System Transformation and Aging Well, also generated lots of good ideas and input. We've been talking with PCORI. They have a funding opportunity on healthy aging, optimizing physical and mental functioning across the aging continuum. So hopefully there's opportunities, once they have findings from those studies, for AHRQ to partner with them on implementing those. We've been talking with many of our federal partners. There's a lot of cross-agency work now, which is really exciting, and also reaching out to many of the foundations and philanthropies that are working in this space. So how could AHRQ do any of this? Just to, maybe for the people who are new to the NAC, we have a convening function. I think bringing people together in learning communities serves an important function. We fund health services research, both investigator initiated and targeted funding announcements. We have the Patient-Centered Outcomes Research Trust Fund that funds dissemination and implementation, clinical decision support and training. We have tools and resources for practice improvement and research, which I think we could do a better job of getting out there, and clearly all the data and analytic capacity that the agency has. So this is my next to the last slide. It's a quote from one of my favorite poems, Caminante no hay camino, se hace camino al andar. Traveler, there's no path. We make our path by walking. But I'm also going to end with a story, because that person walking on that mountain is me. And I'm going to tell my misadventures with the healthcare system too. None of us are immune. I had, an ankle fracture. I have multiple torn ligaments, arthritis. I have one bad ankle, right? I've had 6 really outstanding orthopedic surgeons telling me how I need a triple arthroplasty and more. And it's like, but if I do that, I can't do my passion, which is hiking on uneven ground, and, nobody asks, like, what do you do and what do you want to be able to do? I said I have no pain. I routinely do 10-mile hikes. I do Century. I'm a cyclist. I'm active. Like, what's the risk that I'll be less functional after you operate on me? And I'm just going to tell you one. So I haven't had surgery, and I'm just fine. Thank you. But but the other thing is one of the first orthopedists, with the acute fracture, I have osteopenia. I also have a strong family history of, osteoporosis. So it'd been a while since I had a bone scan. I said, I get a bone scan. Of course, it's easy to order it. So I go back. He's telling me all about the MRI and why I need all these the surgery. And I said, well, could you tell me what my bone density is? Oh, I don't have that. I said, well, could you get it and let me know? He goes, well, I don't treat that. And I felt like, no, I don't want you to treat it, but I want to know before I make a decision about surgery, the state of my bones. And before you operate, wouldn't you like to know that? And then the other thing is, I have a strong family history of premature coronary artery disease. So in terms of healthy aging, talk about multiple conditions, my long-term outcomes would be worse if my physical activity is limited. So I just thought I'd throw in that little personal anecdote there. So here are the questions I have for you. How can AHRQ have a meaningful impact with respect to research, dissemination, and implementation of evidence to improve the organization and delivery of healthcare with the goal of optimizing the health, functional status, and well-being of the US population as it ages? What ongoing and planned related work should we be aware of to avoid duplication and maximize synergies? And what are our opportunities for collaboration and partnership to maximize impact? Thank you.
Thanks, Arlene. We'll take comments from NAC. I wanted to add. I appreciate both the quantitative and qualitative components of your presentation. I think they're both very, very important, very relevant. I want to add there was a few things that struck me. I'm only going to pull one for now, and then we might add more as we go through the discussion. We've got a few minutes for discussion here. But as we think about this, especially as we think about aging, the part that Arlene, that you focused on for a slide or so around the integration of the health and social side of it, I think is really, really critical in this setting, especially as you had already highlighted previously around equity, right? And thinking about the disparities. So I think all of that really comes together in an interesting way. So it may be important to add some comments around that folks might have as you guys have spent a lot of time in this space across the NAC. I see the hands up and I see them in order. So we'll call on folks. Yep, got it. We'll call on folks in order. Appreciate it. Let's go with Cincy.
Hi, thank you so much for that presentation. I have a lot of thoughts, so I'm going to try to prioritize. But in listening to the story you were telling about your in-law's father, one of the things that struck me is that a lot of challenges happen in care handoffs, right? If one person going from one student to the next, or whether then they're going home or whatever. And I am not aware of, and maybe it exists, ways to, like, a hospital cares if they have a readmission before 30 days because CMS makes them care, right? But I don't know if we have a way of, having that going from rehab and a premature discharge back to a hospital doesn't get tagged as a problem with quality of care. In this case, quality of the transitions, right? So that's just one observation that I have, that especially as we're looking at populations as they age with multiple chronic conditions, we need to find a way to flag those falling in the cracks, right? And it seems to be pretty urgent given what we know about, having to fight the AI. And in having to fight the AI, I think it's one of the most interesting pieces that I read recently. It's from a Princeton professor, Rua Benjamin, about the new Jim Code, which is discriminatory design in technology. And we all know that the challenges with AI are the training data. And then we all know that the training data, our data, is extremely biased. So what you end up doing is reifying the existing structural biases from before. So that is another area where I think we need to, digital has a lot of potential to address a lot of gaps, but we also need to be careful about what's the evidence, basically, what is the training data that is being used, and we already have seen examples of how it results in very disparate care. And I'll save my other comments for another point.
Care transitions across multiple sites and settings of care, including across clinicians out in the community. So absolutely agree with you. Also, just briefly, we had a paper in JAMA Health Forum on algorithmic bias a couple of weeks ago, and we convened a expert panel that put together guiding principles of how to prevent bias in algorithms. So it's not what we're talking about right now, but it's really key to advance equity. And I do think equity, is relevant for aging and expanding bias. So stay tuned. It's under review, and we're keeping our fingers crossed that it gets accepted.
Yeah, that's really important work, Arlene. Thanks for sharing that piece. So you mentioned, Cincy, the components around the components around the algorithmic bias, and part of what I often tell folks, and I haven't obviously read your paper yet, so I'm looking forward to that when that comes out. But there's three components the way my simple brain kind of thinks about it. When you think about these specifically kind of machine learning types of predictive algorithms, it's the training data, as you mentioned, right? So garbage in, garbage out, GIGO, right? So you put the data in, and it's already biased, right? There's actually the algorithm itself. The actual build of the algorithm, you can bake bias into the way you design the algorithm, right? So that has to be focused on. And then an important part of, I think it's really important that we have to think about, especially as in health services research, is even if those two components don't have bias, how you apply the algorithm could still be biased, right? So we actually have to pay attention to the application of the algorithm, even if the training data and the algorithm build itself were kind of lack bias. So I just wanted those three components. I really want to make sure that we think about when we think about these predictive algorithms. Kathy, you're up next.
Thank you. As I heard you talking about the need for interdisciplinary care and interdisciplinary care teams and community care moving out to the community and primary care, it occurs to me that it's really important that we are able to tease out the individual characteristics of the healthcare team. And to do that, we need to be able to attribute the individual contributions of the different members of the care team to the member of the care team, whether that's a physician, a nurse, a pharmacist, a community health worker. So I know that we're doing some fairly significant work, both from a policy and a practical perspective, to adopt a unique identifier for nursing professionals that can follow that professional throughout their career. I think that's needed for all our healthcare professionals. It's different when we think about cost of care versus providing care. It's different than the National Provider ID, which is really the only thing that we've got right now. So I would encourage us to really think about how we tease out individual contributions. I also think that there needs to be some focus on interdisciplinary education from the perspective that our professions are inherently different, and some are inherently cure focused, some are inherently wellness focused. And so how do we think about education from the perspective of the need to provide holistic care focused on wellness? That needs to be part of the cultural shift. And then something else that I heard that I think needs to come to the table is that how do we get the voice of folks who are not prepared to publish in a scholarly journal to let us know about all the good work that they're doing and use it? So what are different models that we need to think about in terms of capturing innovation outside of a scholarly publication?
That's a really good point, Kathy. It was one of my other points. So thanks for mentioning it. Right, this idea that there are innovations that are happening out there, and they may not be traditionally on the radar of kind of health services research. ecosystem, how do we ingest those, incorporate those, bring those to the table. So I think that's really really important. Thanks for bringing that one up. Let me just go back so I can get to my view real quick here. Next up was Neil. Yep.
Great. Thanks, Arlene. Great presentation. Two comments, questions. One is, I think building off of Kathy's comments, thing about the healthcare workforce and specifically geriatricians and gerontologists, and understanding when those limited resources but specialists should really be brought in, I think is important. And do you want to respond?
Yeah, I want to
It looks
respond
like
to
you
that
want to
because
say
that,
something.
you know, as one of the few geriatricians in the country, it's the only specialty where you get additional training to make less money. So that might be one of the reasons there's not too many geriatricians around. But there are models, like one of my favorite, and it's a very evidence-based, you know, published in JAMA, the GRACE model, Steve Council and Chris Callahan from Indiana, which is how to support primary care practices to have geriatric competencies. And we need those models. It's been near impossible to scale and spread that model because our payments system just doesn't support that kind. We need to figure out how to pay for that kind of support. We're not going to have geriatricians to take care of, you know, the whole country, but we certainly can support practices and systems on how to get it right. And we need to figure out how to pay for that.
Great, thank you. And the other comment was, as a representative of the business community, I'm hearing a tremendous amount about the caregiving burden that the workforce is experiencing in having to care for their aging parents. And so as you think about evaluating some of these MCC initiatives, maybe one of the outcome measures you could look at is caregiving burden, you know, and the business community's role in helping. Thanks.
Thanks, Neil. David Smith, you're up.
Thank you. I first want to just begin by saying I really endorse many of the concepts and initiatives I'm hearing about today, especially the emphasis on coordinated primary care and transitions. And I also, as a medical educator, want to endorse interprofessional education. I think there's really much to be done there. And the health and healthcare integration with the social realities that patients experience outside the healthcare system, I think really does need to be a meaningful part of the conversation. And along those lines, some aspects of healthcare delivery is dependent, perhaps uniquely than other industries, on geography, on location, especially acute healthcare or procedural healthcare. And you might guess that I'm going to talk about a disparity related to rurality that I don't think I've heard too much about yet today, and would be welcoming any discussion on that, because I think in and itself can be a barrier to patient outcomes we'd rather see, and also that it can be an exacerbating factor for some of the other recognized disparities that we've also discussed. So when we talk about the community care hubs, we do find oftentimes that in rural United States, patients and our neighbors and friends are often older, poorer, and sicker. But that being said, rural resources and rural communities, I think, are often very resourceful, even though they may be less formalized systems of support after receiving acute healthcare or transfer of a patient back to their own community, and may often be under-recognized for that reason. And so in the sense of doing research differently, I would really advocate that we consider a rural lens and a rural context, not only for the importance of discovering what goes right in the rural United States with regard to patient care, but also avoiding unintended consequences when applying new rules or policies or reimbursements with regard to these being applied to uniquely rural and remote situations. Thanks.
Thanks, Dave. That's great. And really thinking about it as, is that a model for how you can scale innovations in very different settings if we learn? No, I love that framework. So Drika, you're up next.
Great, thanks so much. I was so just enamored with all the previous comments and really appreciate them, and wanted to say that I always appreciate your presentations and find them not only informative, but also inspirational. So thank you so much for that. I also wanted to say thank you so much for including really that cross-cutting issue of health equity, especially around race and ethnicity, because I do think we have to continue to embrace how we measure that. And I wanted to add, though, how do we think about the quintuple aim and specifically the wellness piece of the provider, in this? Because we think about our population, how it's aging, our provider population, one is also aging, but then also, people are fleeing. And I think we have to really start to concentrate on physician well-being, physician burnout, and also nursing, and just really all of the folks that are involved in the healthcare team. And if we're going to even have a healthcare team to take care of our aging population.
I want to respond to that because I think you're absolutely right. And I think a lot of the burnout is people go into medicine to care. And when they go in and, they're battling, oh, I have to unmute myself. Okay.
No. We can hear you.
Sorry. I think by fixing the system so that people could deliver the care that they went into medicine or nursing or social work to be able to do, and the system supports them, I think that could go a long way in addressing burnout.
Thanks both. And I want to pull in one other comment from Judge Rico. So it was actually back to the innovations that happen that are not necessarily in the purely academic research setting, right? So then the question that comes up, and this is something for our team to think about, is how in an academic setting, when you have faculty that are collaborating with folks, with innovators, right? I spend a lot of time on the digital side. How do you reward your faculty for actually working with these innovators? What does that model look like? Or are we so kind of stuck in our traditional academic model that we don't actually have a way to encourage and support and reward those types of collaborations? And so that's really something to think about, and something to potentially even propose. If we want to bring this to the table. It goes back to David's comments as well. So how do we reward folks who learn about those different models in different settings, like rural settings? How do we reward faculty that collaborate around that and bring those innovations to bear as well? They're not always going to be pure peer reviewed. They're all in high impact factor journals and so forth. So I think those are important questions to discuss.
So Edmondo?
Yes.
I'd like to just make a quick comment. I totally agree. And there's a whole section in our roundtable report about academic incentives and how they conspire against this. But I'm also a recovering academic. I was a full professor with tenure and endowed chair and everything that people aspire to, and I came to AHRQ. But, one of the things I did get my, full professor and tenure at the University of Toronto. And they have, you still need all the academic, chits, but there's also a category called creative professional activity, which if you could show your impact on a health system, development of a quality measure and innovation. So maybe there's a way that, people could work on spreading that as part of the US academic system, because that could help contribute and let people get credit for all the great work that they do.
That's great. Great idea. Liz, you're up.
Thank you, Arlene, for that very inspirational and comprehensive presentation. And you really laid out an agenda for the healthcare delivery system. There's so many pieces that we can identify and need to be fixed. So there's a sort of a playbook and a plan. And it's very inspiring. And I think the digital piece and the portals and all of those things are relatively new, but also need a lot of addressing some of the gaps to make it easier for patients to navigate. You also spoke about community and social needs. And where do you feel, this is really a question for you, I can see how AHRQ and healthcare delivery systems writ large can sort of handle building on what I just mentioned. But the other big piece, which is community, social needs, and I would say advocacy, navigation, where does that live in terms of identifying resources, programs, and funding? Do we have all the right players at the table? Or is it CDC? Is it local, state, community health? Is it completely innovative programs that we don't even have yet? But it seems to me that even if the healthcare delivery system does everything we could do, that's sort of in our jurisdiction. There are other big opportunities that really need, I think, collaboration with those whose jurisdiction it is, or to clarify whose jurisdiction it should be. What do you think? Oh, I totally agree with you. And I can actually give you some good news on this, because actually dealing with the social determinants of health is not just, health and social services and public health. It's transportation and education and housing. And the White House, has a interagency policy committee that's been working on a report on the social determinants of health for how to, coordinate activities across the federal government. And we'll be releasing a playbook on addressing the social determinants of health. And one of the barriers, so I don't think the healthcare system, right, needs to reinvent, systems that are out there. We need to learn how to play with others, and how do we coordinate, and how do we collaborate. So, but one of the big barriers is we have a lot of categorical funding, right? So we have the siloed funding. And so there's a lot of in that report about how do we braid and blend funding. So braiding is kind of creating synergies and aligning, and blending is like integrating funding. But I do think, we need to be at the table, but healthcare is not going to solve it all. The social determinants are more of a factor in your health than what we do, honestly. The other thing I want to tell you about, so, HHS, if you look at that health affairs forefront piece that we published, that has been, I've enjoyed so much working on that work group, because we have CDC and CMS and HRSA and ACL, Agency for Community Living, we have, there's others, but OASH has been involved, ASPE. So I think we are working across the government now to do this. And I think AHRQ's role is like, we see ourselves as a science partner. As we do all this, we need to learn what works and get the evidence for what works. So yeah, and I think that's one of the strategic questions that we have is like, AHRQ is small relatively compared to these other players. And, how could we best target what we do to have an impact and really support some of the work and provide the evidence for, some of our sister agencies to address this. And then finally, as an example of the kind of things that AHRQ could fund that could advance this agenda, we actually got an earmark several years ago to do something about, chronic disease, social determinants of health, and patient navigation. And what we did was we only had funding because AHRQ is small for 3 grants. We got about 50 applications. We could have funded a whole lot more. But what we asked people to do was to integrate data on chronic disease and community services and social needs in dashboards for primary care practices to better manage high needs, individuals and populations. And these have been incredibly successful grants. They're all finishing off, so there should be a bunch of papers coming out. UCSF, in partnership with 211 in San Diego, has this great dashboard. So for primary care, you could see who's your diabetics, who's food insecure, and what are the resources in the community. So we need to build that capacity. And I think a digital solution that can help people. One of the other grantees was actually Kaiser Permanente, and they developed algorithms. They did look for bias. I asked them about that, to risk stratify people with multiple chronic conditions to see who would benefit from more intense case management. And then the other one was Denver, where they're sharing data. This is a little bit outside of aging, but on incarcerated involved populations and their transition back to the community, and sharing that data, especially for substance abuse and other chronic disease treatment. So I think that's a model for the kind of thing with one, we got $3 million from the Congress, and look how much we were able to do. So, if with small investment, AHRQ can really leverage that. And that's what we want your ideas. It's like, what are the kind of things we could do similar that are small, but, might have a big impact,
Yeah, that's great. Let's see, I'm reviewing the chat as well. Henry, you're up next though.
Thanks, Arlene. I appreciated the presentation. Personally resonated with a lot of your comments, as well as sort of experiences from colleagues and friends. So not a question there, and very nicely described. my comment is a little different than what I've heard so far, because I think what you described are symptoms and signs of a real problem. Symptoms and signs of a problem does not mean we've diagnosed the root causes of what the issue is and why we have this issue. Systems, providers, payers, burnout, education, tech, culture of healthcare, culture of society. I think given what we opened up with is AHRQ is a agency with limited resources and constraints on those resources. And while I personally resonate with a lot of the innovations or interventions you recommended, I wonder if we actually know amongst all the interventions or solutions, the direction and magnitude of impact we could see from any of them, individually or together. If healthcare was agile, fast, and at scale for change, I'd endorse doing all of those things, but we're not. Even when the evidence for the disease or causes of the problem are very strong for randomized trials, it still takes on average 17 years to lead to the kind of change we need to see. And that is our reality. So we're proposing things without that evidence base. And I wonder if we truly understand the problem to say, hey, if we do this, this is the impact we'll have on better elder care and a better healthcare system.
So I totally agree with you. And I think one of the approaches we've taken, with the PCOR Trust Fund is integrating, implementation science and quality improvement. And I think that's where AHRQ could, add is like, yeah, we're not going to do it all, but how do we strategically, what should we strategically start, and, talking about so we need the evidence, like what works, like what models work, what clinical interventions work, but we also need the evidence on how do you make it work? What, how do you implement, how do you scale and spread? And I would welcome your ideas on what little piece we could carve out that would actually make a difference.
Yeah, and I love Henry. I love the concept around what's the potential kind of spread of impact? Like just how big is this going to be? How much is this going to move the needle? Is there a way to measure that even as we're thinking about the implementation science aspects as Arlene described? Cynthia, you're back up.
Thank you for giving me another opportunity. So the other area where I have a lot of questions is, why is it saying that I need to unmute to start speaking?
No, you're fine.
Ignore it? Okay. Thank you. Is basically, in thinking about multiple chronic conditions as people age, and you mentioned weathering as one of them. And so I am curious about what AHRQ and other researchers could be doing about interventions that address weathering, allostatic load, the impact of ACEs, because there's increasing information about how this has all these factors have an impact. But I think on the side of what do you do about it, other than prevent them, is very sparse. So I was wondering if you had any thoughts about that, and then related to that in general is that we really need to force the research community to require the disaggregation of data and stratification of results by race, ethnicity, and disability. We have been saying this for, this year is the 40th anniversary of unequal treatment, and we still don't have the systems in place and the ability to look at these kinds of results. So I think that needs to be the cornerstone, foundational to any, project, any work especially work that the federal government is funding.
Thanks, Cynthia. So Caroline, you're up.
Thank you, and thanks for the talk today. I tore my rotator cuff earlier this year and haven't been able to swim, and was lucky that my providers recommended physical therapy only. So there are some good ones out there, and I would love if we could figure out how to, as it was said earlier, get those evidence-based practices to go across our industry. I wanted to speak from the insurer's perspective first, and that is the need to collaborate with insurance companies in the research that is being done going forward in this area. It is unacceptable to have an algorithm dictate a discharge from a nursing facility or any other facility for that matter. And denials are only supposed to be done at the hands of a physician. And we know in some very large companies, automation is key because they just, want to put things through. I think we have to balance what's happening in that kind of setting against the quality issues that you so sadly raised in the description, and where it is that there is value in doing what an insurer does and how it needs to change. And I don't think we can get there unless we really bring together that kind of partnership between the agency and the insurer. I think it's going to be critical to do that. The second is value-based care often incents the wrong things. So there are insurers who will have value-based care for downstream home health providers to limit the amount of spend or the amount of care, and then they will have an upside potential at the end of that. And that kind of thing is going to over and over again lead to that same bad outcome for short-term financial gain in a value contract for a very terrible clinical outcome. So again, something that I think really needs to be taken under scrutiny in that kind of research setting. I think there is a lot that could be done, and those partnerships make a ton of sense to me. The second thing I wanted to mention is I did have a technical issue about probably for 3 slides. So I don't know if you mentioned the effect of behavioral health care on seniors, recent reports of how challenging it is for seniors to get geriatric psychiatry, and how collaborative care may be one of those kind of solutions where we could start getting that right. So we can spread that psychiatric expertise across many primary care providers. So thank you for your comments today.
I agree with you. I actually did not talk about behavioral health. I just had to, cut down my talk, but that's actually, totally critical. And we do have a whole section on that and talking. And again, collaborative care, models, again, are effective and have been near impossible to scale. So, when you get the roundtable report, there's a section in there, and we would love your ideas on how we could, address that.
Not to call attention to my own organization, but we're scaling collaborative care and have the technology to be able to do that now in a very effective and simple way. So I think that future is now here, and I would be delighted to touch base with you on this.
Love to learn more. Great.
Yep.
Thanks, Caroline, for volunteering for that work. And let's move over. Let's go back to Kathy.
Yeah, thanks. I just wanted to piggyback on Henry's comments, and Carolyn, you brought this up a little bit too. What obligation does AHRQ and other federal agencies have for incentivizing the implementation of what we already know is best evidence? So as we, studies that I've seen suggest that we've probably got pretty good evidence for about 70% of our major problems in healthcare, but what incentives do we have to actually implement it, as opposed to generate more knowledge that probably contributes to the same body of evidence rather than just implementing the evidence that we've got?
I would turn to Bob. You might want to mention expect.
No, I want to just say that I remind you that AHRQ has certain authorities, and incentivizing with dollars is not one of them. But our sister agency at CMS has the power of the purse. We at AHRQ need to rely on the power of persuasion. And so I will be meeting with healthcare executives and board members and others of health systems this coming week, for example, to talk about what we do know to improve patient safety and workforce safety, and to create the culture of change and transition that we have talked about before, the need for transformation of healthcare. And that's what we have to rely on. And we rely on you and our partners to actually make that change possible.
Thanks. David Atkins, you're up. You had a couple of comments in the chat. One, because you brought up workforce, which we haven't focused a ton on here, as well as some of the things that you all are doing in the VA, but you're up.
Yeah, I won't repeat everything that I put in the comments, but I think, VA and AHRQ share the problem of having limited resources and trying to find our sweet spot relative to the 500-pound gorillas. So in terms of looking at what you'll be aware of and for synergies and avoiding duplication, I was just looking at NIA's strategic plan, and they are getting into a lot of the areas that traditionally, like caregiving and community care. But what's really missing is a focus on the primary care workforce as a place to kind of expand capacity for caring for older veterans and older patients, sorry. And similarly, the sort of coordination with services and community, and then along with other people's comments is thinking about the business case, right? So the reason things like GRACE have not been scaled is because the difficulties of creating the business case for, an improved models, and NIH isn't going to really be looking at that. So thinking about those issues, and caregiving is another example. VA has been able to expand caregiving because Congress, gave us money to do that, but a health plan isn't going to have that option. And so trying to figure out how do you redesign care involving caregivers, primary care, community in a way that has a business case to kind of shift resources from, the wasteful spending into higher value spending. And I think that's a place where you would have, partners. Thanks.
Thanks, David. Sherry, I see you up.
Yes, and so I just wanted to also pitch in a response to the question about when and how are we able to provide different incentives. CMS is very much a implementation agency, like was said, with specific authorities to implement. So, as a federal partner, our agency will work closely with Agency for Healthcare Research, leadership, and on not only, clarifying what evidence is needed where there are gaps in care to change, but also apply different authorities that utilize that evidence. Some examples are in the quality improvement space, where there are signals of need for improvement, patient safety that has gone awry, and AHRQ provides evidence tools that CMS can then encourage the use and uptake of through the usual vehicles of depending on which CMS authority is in play. Quality measurement is a critical and relevant authority and an action arm or policy lever, if you will, that likewise builds on the work that this agency implements and has developed. And likewise for payment considerations, we've heard the need, including in the behavioral health space, to improve by way of different payment vehicles, focusing on value-based care, as was mentioned earlier. And most of that goes through notice and comment, public comment and rulemaking. So I think, the exciting part of Arlene's presentation is really to also delineate the focus on aging and the important distinction of aging versus disease, and what might be efficient is how CMS and Agency for Healthcare Research and Quality works together, which is to identify what those opportunities are to pull the findings to support forthcoming policies and rulemaking. And in doing so, it's really necessary to identify not only the lever, but specific authorities, including benefit categories, just noting that CMS's ability to support preventing something is significantly less than paying for illness that has already become apparent. So I just wanted to throw that in for your consideration and awareness. So thank you so much, Arlene. Always terrific to hear you present.
Thanks, Sharon. Thanks for that perspective. I think that's important for the group. This topic is out of time, but I saw you, Mireille, jump on. So I'm going to let you have the last word on this topic before we go to lunch.
Thanks. I'm going to make a really quick comment, which is I think I want to push back on the slide about, we can't use RCTs here. I think actually my head is swimming from all of the different things we've talked about. And I think this is a case where actually we want to really push on pragmatic randomized trials. And I'll just, end related to Sherry's comment that where are we learning so much from CMS's kind of, different experiments? I see a lot of the big kind of learning from CJR, the comprehensive joint replacement model, where randomization was built into it. So it's not randomization and RCT like we do for a drug approval, but it does allow us to really make causal claims. And I think we shouldn't lose sight of that.
I agree with you. I was just saying we need to think beyond that, and also how we do those RCTs, so pragmatic trials, but also adaptive trials. Like I think it's a problem when we have a hypothesis of what's going to work and it's not working, and 5 years later we have a negative intervention. So can we do rapid cycle or adaptive trials where we're kind of improving the intervention as we go?
I agree. So great. Thank you.
Thanks all. Robust conversation. Really appreciate everyone's engagement. Arlene, as always, great presentation and setting up the group for the conversation. We're going to break for lunch. Exactly 18 minutes is what you have for lunch. We're here back at 1:20 sharp. I would encourage you to probably bring your lunch back to the table so that we can start sharp at 1:20. Okay, thank you. reiterate for the public the opportunity to make a comment in what we call real-time post by sending an email to National Advisory Council at arc.hhs.gov with the subject line real-time post, and your post can be added into our chat as part of the record. And again, be respectful with your comments and the real-time posts. Let's jump into a discussion on consumer experience measurements, led by an all-star cast here. Henry Ting, who's the SVP and Chief Health Officer at Delta. Julie Brown, Director of Survey Market Development at RAND. Robert Weech Maldonado, Professor of Department of Health Services Administration at UAB. And our esteemed Director, Dr. Valdez, in terms of bringing this really interesting and hopefully robust conversation around consumer experience measurements. So I think, Henry, I think you're first. So why don't you go ahead and take it away?
Thank you, Armando. Thank you, Dr. Valdez. I only have maybe 10 minutes of comments, no slides. And I was asked by Dr. Valdez and the AHRQ staff to give an assessment how we currently measure quality and experience in healthcare, and perhaps provide a provocative and critical assessment of that. My lens and perspective, for those of you who don't know me, I come from as a health services researcher, outcomes researcher, most recently the Chief Value Officer at the Mayo Clinic, previously Chief Quality Officer at New York Presbyterian, and currently for the last 3 years, a senior executive at Delta Airlines, which I call a consumer-facing business. And I hope my comments here could be taken from the vein and context of what is possible and how we can change to become better, just as Dr. Valdez challenged us in the beginning. My comments start with, we rate Uber drivers, restaurants, hotels, and much more. But when it comes to healthcare experience, we often have little to no data. And in our third-party payer business model, which you've heard about, the patient's not the customer of the healthcare system. The patient is merely the reason for a business transaction between the insurance company and the healthcare providers. I truly believe as a healthcare provider that doctors and nurses and hospitals and pharmacists, they're genuinely patient-centered. And they believe that and they act that way. And they're trying to do what's in the best interest of their patients. They're focused on things like we have the best doctors, we have the best nurses, we have the best researchers, the best students, the most advanced technology and equipment. They often behave, in a manner that they know what's in the best interest of their patients without truly understanding their values, preferences, and goals that we've heard about. However, I would posit that being patient-centered is not equivalent to being consumer-centered. I draw you to Jeff Bezos at Amazon, who's often quoted as saying, Amazon doesn't exist without its customers. And being consumer-centered means you're obsessed with your customer. And what are you obsessed with? Seeking to delight them and building brand loyalty. I would posit that few hospitals and providers actually seek to differentiate themselves by delighting customers, exceeding their expectations, or building brand loyalty. We want you to keep coming back here for your future care, and we'll make it easy for you. Maybe the CEO and the chief marketing officer of the hospital or the healthcare system may care a lot about service, brand, loyalty, and volumes, but I'm not sure the emergency medicine physician or the ICU nurse is thinking about that when they're providing care. So at the risk of oversimplification, and I thought about this in terms of all the measures we have, we could define today's measurement of healthcare in 3 broad domains: metrics about quality of care and experience. And quality of care metrics are indicators to evaluate how health services increase the likelihood of desired health outcomes. Number 2, metrics about need and utilization of care. These metrics gauge population health and how often someone uses a specific service they're eligible for and should get. And number 3, metrics about value-based care, right? These measures try to measure disease prevention rather than disease treatment. They try to incentivize actions to prevent illness before they happen or to reverse them. But if you asked our consumers, who are our patients, what do they care about? What do they truly care about in quality of care? What I hear, including in the healthcare sector, as well as a major employer with 100,000 employees and another 150,000 dependents on our self-insured health plan, they care about speed to diagnosis. I have these symptoms and signs. How quickly can you diagnose and treat me? Is that measured in minutes, hours, days, weeks, or months? Number two, they care about the accuracy of that diagnosis. Did you get the right diagnosis and the right treatment for me? Am I getting better? With regards to service or patient experience, my experience is that patients care about three things: navigation, access, and coordination. Navigation means, who do I need to see for my symptoms, signs, or condition? Most patients don't know. They have no literacy or knowledge of this. Number two is access. Which providers in healthcare system provide timely, consumer-driven, on-demand, 24/7 access today? Number three is coordination. Coordination is who has my back? Who's going to make sure that the follow-up CT scan, the lab tests, the cardiology visit, the GI visit, the rheumatology visit is scheduled for me and advocates for me? Or do I have to do that myself? In most consumer-facing businesses like Amazon or Delta, we measure experience or satisfaction with a net promoter score. So whether that's on a scale 1 to 10 or 1 to 5, we take the 5s, we're called promoters. We subtract out the detractors, the 1, 2s, and 3s. And that's the net promoter score. And then 4s are passives. CAPS are not measured that way. We don't really get the people who are detractors or passives. We get percent top box. So when I thought about CAPS and I reviewed the origins of CAPS, I started with HCAPS, right, the hospital CAPS, which was intended to measure patient perceptions of their hospital experience, patient perceptions of hospital experience. It was developed over 20 years ago in 2002, implemented by CMS in 2006, and publicly reported for the first time in 2008, 15 years ago. And AHRQ, with its stakeholders, carried out a really rigorous scientific process, including public calls for the measures, reviewing the literature, cognitive interviews, consumer focus groups, stakeholder inputs, a 3-state pilot test, extensive psychometric analyses, and consumer testing to get where we are. So my assessment 20 years later about the strengths are, it's the first national and standardized survey of patient experience. It's a technical measure that measures more scientific criteria. Is it reliable? Is it valid? Is it feasible to be collected? It's transparent, it's publicly reported, and you can compare hospitals, all good things. What I think our opportunities are, does it truly drive improvements in patient experience and meaningful use of our resources, the millions of dollars of people, time, and money for all of you who work at hospitals? Does it truly drive improvements in patient experience? Are these measures the most meaningful one to our consumers and actionable for the hospitals and providers, and meaningful in the sense of navigation, access, and coordination, and something that the hospitals and providers feel like they can do something about? You know, at Delta Airlines, just to draw an analogy here, we know our customer experience, the NPS, is driven by 4 core things. And if we don't do these 4 things, there's no chance we can delight the customer. Safe, clean, on time with your bags. If we don't deliver that basic promise, there's no way I can delight you. What's the equivalent in healthcare? Safe, clean, on time with your bags. Often, you know, the most important question I find in the HCAPS is your overall hospital rating, right? That question at the end, how would you rate this hospital overall? It's problematic though, although it's the most important question, because I would posit that, do patients really have great alternatives and options to go to another hospital provider? How many have received care at a sufficient sample size or number of hospital providers to actually provide a comparison rating when they fill that answer out? And what about all the consumers that never got access to your hospital because they couldn't? They're never sent a survey. So, you know, you guys know what the 29 CAPS questions ask. You know, they ask about the nurses, courteous, respect, listen, doctors, Was the bathroom clean? Was your room quiet? You know, all these technical questions, which are, you know, measurable, feasible, past psychometric testing. But I'll just give you a simple example most of the providers in this room have experienced. Imagine that you were admitted or your family member or friend was admitted to hospital with abdominal pain, and you were MPO after midnight for that CT scan that your doctors ordered. And it's 6 o'clock and you're told, well, you know, we can't get you in today. Sorry. You could probably score top box on all these HCAP measures because you communicated, you're respectful, the bathroom was clean, the room was quiet. But did you really delight the customer with that kind of message at 6 o'clock when they've been in PO since midnight? And when I thought about the CG caps for outpatient care, some of my initial thoughts for research purposes were these measures look at a single encounter. In healthcare, we know is longitudinal. They're not one visit with Armando. There's not one visit with Liz. There are multiple visits over time. And how do we measure that span of care? How do we measure experience in the virtual world, right? With the telemedicine, the virtual consults that we have. What about the asynchronous digital communications that patients are increasingly using through the portals and their interactions with providers? And lastly, I think we all know care is different for different presentations, right? If you're presenting for a healthy physical exam, a simple vaccination, a simple screening, surveillance, mammogram, or colonoscopy, how do we measure that experience versus the experience for really complex care when you have the worst headache in your life or you have chest pain that's not going away? Do our surveys get to those granularity of differences? So at this point, I know I've asked more questions, but we'll pass it on to to Julie.
Turned on her mic. Hopefully will almost delight you. We'll pull the mic closer and use my training voice. Well, so delighted to be here to get to talk with you all about patient experience measures. And I think it's so timely, Henry, that you brought up HCAPs. I don't know if any of you are aware that CMS has just wrapped in conjunction with AHRQ and the CAPS Consortium, a 2-year effort to refresh HCAPs. And so a revised version will be rolling out along with their results from their most recent, very large, very robust mode experiment to inform methods for the survey. Similarly, CG CAPS totally acknowledge that the visit-based survey does focus on a single encounter, but want to remind us that the most broadly used survey is in fact the survey that has a 6-month look back period. And so really looks at the relationship with an accountable care organization, a group practice, or a provider or other care setting. And I think that these are important issues to lay out on the table and discuss because they provide an important framework for the conversation that we'll likely have later about what it means to measure patient experiences. How do we move forward and prepare for what, Bob, the 24th century, and have what I've heard you all talk about, thoughtful and important allocation of the fixed resources that are available to focus on these important issues and address them. So to reorient back to what I was asked to do here today, I'm here to talk with you about patient experience measures and their importance as a tool to improve healthcare quality and patient-centered care. After my road trip or sidebar, I will now touch briefly on the different types of patient experience measures and share some challenges and considerations for the future. Patient experience, this is really multitasking at its finest. Boy, patient experience refers to the overall perception and interaction a patient has with the healthcare system or setting. It differs from patient satisfaction. So it includes the patient's interactions with clinicians and the others who provide their care and the environment in which care is delivered. It can encompass the entire patient journey from the moment they seek care to their post-treatment follow-up. Or it can encompass a single point in time or specific visit, as Henry has already mentioned, or a single episode of inpatient treatment. Patients provide reports on their experience and ratings of the care they received, focusing on the aspects of care that patients have told us are important. And that includes things like access, communication, coordination, engagement, conversations and questions about the setting or the environment. Patient experience is a comprehensive concept that focuses on understanding the patient's perspective to improve the quality of care and patient centeredness. It differs from satisfaction in that satisfaction is a narrower measure of like their overall contentment with their care or how they feel about a specific episode. So one might be more emotional, so to speak, where the other one is more than a report on what your experience has been and tell us what happened, what occurred, so that we can understand the quality of what you received. So why does it matter to measure patient experience? First, it improves patient-centered care by ensuring that healthcare delivery is aligned with patient preferences, needs, and values. It emphasizes the importance of placing patients, or consumers, if you prefer, at the center of care. It promotes quality improvement because patient feedback provides valuable insights into areas that require improvement within the healthcare system. By measuring the patient voice, organizations can identify and address gaps, deficiencies, and make evidence-based changes to enhance and improve the quality of care provided. Measuring patient experience fosters accountability within healthcare organizations. It encourages them to be transparent about their performance, both their strengths and areas for improvement. It facilitates the evaluation of their services by patients, regulators, and the public. You all talked earlier about value-based programs, and patient experience measures are an important part of value-based programs and are in use in many value-based programs, including those promoted by CMS. Measuring the patient voice empowers patients to actively participate in their care. It acknowledges their expertise in their own health and allows them to express their concerns, provide feedback, and collaborate with healthcare providers in shared decision-making processes. Patients who feel heard, respected, and engaged in their care are more likely to continue seeking care from the same providers, to recommend the organization to others, and more likely to adhere to treatment plans or advice or guidance from their clinicians. Patient feedback contributes to the generation of research and evidence in healthcare. By capturing the patient voice, healthcare organizations and researchers can gain insights into patient experiences, outcomes, and preferences, leading to evidence-based practice and policy development that can be rolled out across multitude organizations. So let's talk briefly about the key dimensions of patient experience of care. They include all of the things that Henry mentioned and that others you have mentioned in your earlier conversations: communication and information sharing, access to care and appointment scheduling, care coordination and transitions, whether it's transition from one care setting to another or transition of information from one provider to another. That is information from your specialist getting back to your primary care provider so they can help promote your health and follow-up. Respect, dignity, and cultural sensitivity to the patient, emotional support, and patient engagement. These dimensions represent the key areas that influence the overall patient experience of care and that patients have time and again told us are important to them in identifying a quality healthcare experience. Healthcare organizations strive to address and improve these dimensions to provide a comprehensive and patient-centered experience. So let's talk briefly about the different types of patient experience measures. As you know, CAHPS is one survey-based measure of patient experience. Other survey-based measures include things like patient-reported outcome measures. But there are also other important ways to measure patient experience that aren't survey-based. This includes patient shadowing, which is where a member of the quality or customer-facing team shadows or tracks the patient as they navigate through their journey with the healthcare system. It can help identify pain points or barriers in care, connections that don't happen the way that they should, or things that prevent patients from getting the very care and services they need. Patient interviews and focus groups can provide very rich information to help shed light on the more standardized information or numbers that are collected in a CAHPS survey. Henry talked about looking at top box scores. Many CAHPS programs look at mean scores or scores for the composite measure. But getting information directly from patients in a qualitative way through interviews and focus groups, again, can shed light on the experience behind those reports and ratings and give you that deep, rich information that can help you kind of unpack and unpick the barriers and problems. Online feedback forms and patient comment cards can be really useful in getting real-time information on things that can be tweaked real-time, like the quality of food in a hospital stay, challenges your family members faced in parking, issues you had navigating access to a building. You know, those are all things that may not be appropriate for a standardized survey, but are easy to measure in those quick ways. All right, I've got 2 minutes, so let me jump quickly ahead. I will touch briefly on CAHPS surveys simply to remind you that they measure the aspects of experience important to consumers. They're tailored to healthcare settings. And I think the value of what AHRQ did in promoting and developing the CAHPS program was to create this petri dish in which really important qualitative and quantitative testing could be done so that best practice and best survey science for measurement and reporting and data collection could move forward. Challenges. I think we've all heard these challenges. I think we all go to meetings like this and we hear concern about response rates, mode of administration, the cost to administer surveys. There are challenges in figuring out what's the best way to collect information for my patients. I think we all are worried about survey fatigue. Are people getting too many surveys? How do we work together to try and identify ways to collaborate or combine different survey initiative needs? Language barriers and health literacy. The emphasis on equity and patient-centered care is a beautiful thing in that it causes us to think about all the different patients we serve and how do we collect their information. And so it's important to have surveys that are available in the languages that are preferred by these patients. Last, one additional challenge is having in-house expertise to analyze and understand the data so that you can act upon it and build programs that are meaningful. As we move forward through the conversations today, I want to leave you with some considerations for improving patient experience surveys in the future. Simplifying and streamlining survey questions, I think, is a great goal and something to think about. It promotes comprehension across the spectrum of patients, but also promotes translation. I think there's an opportunity here to explore tailoring surveys to specific populations. As Henry mentioned, patients presenting with specific kinds of conditions or needs. This is really a great opportunity to use surveys and survey samples to drill down on those populations. I think that this is a great time to be thinking about how to optimize survey administration procedures to take what we learn and know about what modes work best to collect information successfully from different populations and make sure we're sharing that broadly so that people can act upon it. Provide more or better tools to translate survey results into actual actionable quality improvement initiatives. I think there are some great tools out there, but there's always room for improvement and more, but also in thinking about how to make them accessible to the people who need them. Again, as I already mentioned, coordinate survey methods to minimize survey fatigue among patients and think about the practical barriers to doing that. And is there a way to do that? And last, and in many respects, most important, continued research to evaluate and improve survey design and the procedure for survey implementation, making that information publicly available so that those who are on the front lines of survey administration and management of patient experience can benefit from the research that's been funded by agencies like AHRQ. Thank you.
Yes, hi, everyone. Rob Maldonado, and I'm going to be talking a little bit more about the research that I have been doing for some decades now in relation to racial ethnic disparities in patient experience and the role of, or potential role of social competency. Here.
Just that, Michael.
Oh.
You're on.
Send that one on.
This one. That one.
Hold on.
I know a lot of multitasking, right? Really. All right. So, it was actually since the early 2000s that we started publishing work on racial, ethnic, and language differences in CAPS. At that point, we were looking at Medicaid managed care. And, but, it's kind of interesting that even today, more recent work that we publish, we still see some of those disparities. And in this slide, as you can see, we actually compare the experiences of Hispanics with those of whites in Medicare, including both fee-for-service and managed care. And as you can see in this chart, there were particularly 4 domains where Hispanics had lower scores than non-Hispanic whites in getting needed care, getting care quickly, getting drugs needed, and flu immunization. So it is this type of work that actually kind of got my attention in looking at potential strategies that might be used in order to address some of the disparities. And that's where my work on cultural competency came into play. And also would like us a little bit of background. This was a recent article that was published in Modern Healthcare, and the title was Patient Satisfaction Surveys Earn a 0 on tracking whether hospitals deliver culturally competent care. And the author says each day, thousands of patients get a call or letter about being discharged from U.S. hospitals. How did they stay, go, and things that that Julie talked about, right? But other crucial questions are absent from these ubiquitous surveys. In terms of perceived discrimination and other aspects that might impact more directly diverse patients. So this is just to give you a little bit of background, on cultural competency. And as a footnote, there are many terms that can be used for cultural competency. But, in essence, the main goal of cultural competency is to improve the quality of care for diverse patient populations. It is viewed as a potential strategy to address health disparities by addressing communication and other institutional barriers that may be a result of language and cultural differences. Now, one definition, there are multiple definitions of cultural competency, but one that I use here comes from the National Quality Forum, and it's from a health systems perspective, right? That it has to be a systems approach, right? An organizational wide approach, that it's actually implemented through policies, learning processes, and structures. But this definition also calls the attention into that it has to be an ongoing capacity, right? It's not like systems become culturally competent. It has to be something that organizations strive continuously to improve upon, depending on changes in the healthcare environment or patient populations. Now, I'm going to be talking about my work specifically on measuring and looking at the effects of cultural competency. And if you look at cultural competency, it can be viewed at 3 different levels: at the organizational level, patient level, and provider level. And I have given you here examples at each level: the cultural competency assessment tool for hospitals, at the organizational level, at the patient level, the CAPS cultural competence item set, and at the provider level, the healthcare provider cultural competence instrument. I'm going to be focusing on the first 2, on the CCAP and the CAPS cultural competence item set, since those are the 2 instruments that we develop and also have tested. Okay, and this is kind of like the conceptual framework for the CCAP, the Cultural Competency Assessment Tool for hospitals. Like I said, it's view cultural competency as a systems approach that has to be integrated into both the management and clinical subsystems of the organization. From the management perspective, we're talking about leadership, the management systems, operations, workforce diversity and training, data collection and quality improvement, and community engagement. On the clinical side, we're talking about patient-provider communication, care delivery, and supporting mechanisms. Now, I would like to indicate that key in all of these is leadership, right? That you need to have that leadership commitment if you want to have change in the organization and becoming culturally competent. So we did actually some tests of this instrument with California hospitals where they completed the CCAF, and then we merged that data with AHRQ's data, and we found that those hospitals that score higher on the CCAF had better patient experiences, or patients score higher in terms of physician communication, hospital rating, and recommending that hospital. And for minorities in particular, there was an interaction where minorities in those hospitals that had higher CCAF scores had better scores in terms of nurse communication, staff helpfulness, as well as the environment, and also pain control. Okay. Moving now to the patient level, like I said, that was on the organizational level. The patient level, the CAHPS cultural competence item set, you can see in this framework at the intersection of patient, provider, and healthcare system factors. There are 6 domains that we highlight. One of them is the patient-provider communication, which of course CAHPS does a great job in looking at that. Then you have things like shared decision-making, trust, experiences of discrimination, health literacy, and language services. Now, my research in particular look at perceived discrimination and looking at a population of Medicaid managed care patients in Florida, and we ask about their perceptions, right, of discrimination. And then we merged that data also with CAHPS data, and we found that those patients that perceive discrimination had actually lower scores on CAHPS, ranging anywhere from 15 points lower for things like getting needed care to 6 points lower for specialist rating. So definitely there is, an importance about these domains to be captured. I would like to also make or mention about CMS also health equity efforts currently. One of those efforts is about reporting both CAHPS and HEDIS data, publicly reporting this data by race, ethnicity, sex, and rural urban status. So that will provide also a way of comparing health plan states in terms of their health equity efforts. Also, there's actually a field test. Julie already confirmed it's completed. She's involved in that project about a specific survey question about perceived unfair treatment. And this is how the question is framed. In the last 6 months, did anyone from a clinic, emergency room, or doctor's office where you got care treat you in an unfair or insensitive way because of any of the following things? And as you can see, it goes beyond race, ethnicity to capture a lot of other dimensions of diversity. So, so this is, one effort in moving into capturing some of these domains that may not be currently captured by CAHPS. Thank you very much.
Thank you very much for your presentations and for your provocative statements in some cases about where we need to be or what we should be thinking about as we think about the patient or the consumer's journey through the healthcare process and facilities and processes. I'm not actually going to take a whole lot of time other than to encourage all of you to share your comments and concerns, because I know we have an opportunity to begin to discuss this earlier informally, and certainly I'd certainly like to hear your formal suggestions for how we should think about this moving forward.
Yes, so yeah, thanks for all the presentations, framing the conversation, provoking the conversation as necessary, and making sure that we have broad aspects and inclusive around this topic. Let's open it up at this point to questions or comments from NAC members, you can bring in some of the comments or conversation from the pre-work that we did before the meeting officially started, if you think that's appropriate. We will have some time to report out formally a little bit later, but it's certainly relevant to bring some of that conversation to the table if you think so. One question, I'll start as folks can do the hand raise thing on Zoom to jump in. One thing I'm wondering about, especially as we were talking about, or the last presentation around measurement, and I started thinking about, well, especially with that CAT thing you call it, that you know, is there a measurement around structure and process and outcome that we should be paying attention to, and what is outcome at the end of the day? So have we fully defined that? But are there actually different levels of measurement that we should be considering as we tackle this? I don't know, because your framework made me think about that. Yes. Yeah.
Yes, that's an excellent question, and that's in part why I made that differentiation between different levels, because different levels capture different types of information. So at the organizational level, you're able to be better informed in terms of what the organization is actually doing in terms of policies, practices, for example, the availability of interpreter services, whether they have diversity training, things that are more that, like you said, structural elements. While the patient, of course, provides more about the processes, right? Their perceptions about the processes. So I think it is important. Now, how you capture that information, of course, it's the challenge. But yes, definitely, that was one of the reasons why I was reporting about that. Mm-hmm.
Yeah, that makes a ton of sense. David Schmitz, I see you up first.
Well, thank you for the opportunity to have this discussion. I think it's really foundational when we talk about research that we have a methodology that gets us to the meaningful impact we're trying to accomplish. And I just wanted to start by saying sometimes complex or difficult methodology is worth it. And I wanted to
endorse much of what I've been
hearing
and also talk a little bit about
patient shadowing
as an example of a somewhat complex methodology. But I wanted to tell you a story from my practice as a rural family physician. I think that's one of the reasons I'm here. The CEO of our local critical access hospital would deliver the paper to every patient room. And if the patient wasn't able to read the paper, one of the family members might be able to. But he wasn't just delivering the paper. It was a. Do we have an echo?
But it wasn't, I think the mic's turning on automatically, apologies. It wasn't a daily paper, it was a weekly paper, but it engaged a survey sampling, essentially a process of survey sampling that I think really was enlightening and also was informative to nurses, to providers, to all of us with regard to that patient experience. Also in this town of 2,302, give or take the day if we delivered a baby that day, family physicians were providing care in the hospital, the clinic, which was physically attached to the hospital, to our extended care facility, and also receiving transfers in and out of this isolated location. And I think that what was really noticeable is we were taking care of our next door neighbors, in some cases our friends, managing those dual relationships, and also your children's school teacher, for example. And so the consumer experience is palpable in those scenarios. And I think while we don't necessarily see the same sort of indicators utilized with regard to survey techniques or in fact what we're measuring, I think it might be a unique opportunity because it's a relatively closed system analysis. And it's also a place where there's unique continuity of care. So I just wanted to express that I think this is difficult work, but it's really worthwhile.
Thanks, David. Liz, I actually saw you come up and come back on, so I'm gonna go to you next.
Thanks. Henry brought up an example from outside of healthcare when he talked about Delta. And I was thinking about another example that many of us in the room and on Zoom may have experienced, which is dealing with car repairs. The car service industry seems to be very focused on your experience. And one thing that they do is that they ask you when you're done, what did we not do to delight you? And so they ask, because you might do really, really well on all of the things that are technical or process measures, but you're still not happy because of something that they didn't ask you about. And from a research perspective, it would be an open-ended question. And I know all these surveys have, comments and things like that. But if there was a way to more intentionally do that, like I'm just going down a rabbit hole here, but I think it could be designed so that every 10th survey, someone calls and said, hello, Julie, you gave us this score, but what we could have done to make it really better. And then to pull that together, not with a big enough sample to have heft, but not too big of a sample to be not feasible, and find out thematically what we are missing. And do it from patients from both inpatient, ambulatory centers, and then call patients at home, because those are the ones that are likely sitting there and worried about things like coordination or access or navigation, or did they get the diagnosis right? I think that might break us out of what we've been doing. And I think we've been doing a great job with HCAPs and CGCAPs, but the healthcare industry is just completely different now. So that's just a thought I had. Wondered if you had any comments from the speakers.
I love all of that. I think that's great. And the CAPS team, narrative elicitation, trying to figure out how to capture that open-ended information in a way that is more detailed and more actionable, and look better than that. Everything was great. Kind of understanding, where didn't we delight you and what particularly happened? Tell me more about it so we can get an understanding of how it happened. I think those are really important questions to include. And I agree with you 100% that the challenge is that, we can't always ask them of everyone, but asking them of enough people to get some information and then acting upon it, following up, and then taking a pause to say, what did we learn? What can we change? And then looking at future comments to see kind of how effective was that? How did that work? I think that's a great suggestion. It can be a really powerful resource.
Thank you. I'm going to take chair's prerogative here, and I'm going to call out Krista to ask any thoughts or comments based on the presentations that you saw here, as well as your extensive work as an advocate for these folks that we are addressing and trying to care for here.
Make sure I'm not an echo. So I'm a private patient advocate. So I work every day with patients, and you talk about all this patient experience. In my opinion, and I don't mean this disrespectfully, but you get these surveys and it's beeping at me. Are y'all okay? So you get these surveys and we either delete them or why turn them in? Nobody's going to do anything. And a lot of them don't even pertain to what their problems are. Medication management, coordination, care. I do all that. And we've got to come up with a way to capture that if you want to change healthcare. And it's through storytelling or their narratives. You can gain so much from just listening to a patient. And I don't think the healthcare system does that well. And I know there's, shortages and short on time, but I do think as an advocate, I can find out what someone needs in 15 minutes. And it's just, these surveys have got to be more relevant to the patient. And right now they're not.
Al, jump on in.
Thank you, Mr. Chair. First, I thought it was a great presentation by all of you. As a pharmacist, my mind is just like spinning over here as far as there's a disconnect. And there's a true disconnect as we look at the healthcare model, we look at the interdisciplinary team, and we look at it from end to end. What pharmacies are asked and surveying on are totally different than what I'm hearing today. And so there's a challenge there, one, in that we're not all on the same page on that healthcare experience and having that value-based care and that quality of care mindset and metrics on that. And I don't know what the solution is, but to go back to our pharmacy leaders and to ask them how to change it, I would look for any input from all of you as far as what we need to do differently. How do we need to request, you know, in those conversations with CMS and others on some of the things that we have to survey on, what do we need to look at differently than what we're doing today? Because there is a huge gap, and for us to fix this model, I mean, you just said medication management, some of those things, like pharmacists do a lot of that, but we're not surveyed on that, or we're not surveying the patients on that. We're surveying on how clean is a pharmacy? How long did it take you to get your medication? And so it's a discombobulated, you know, a process or approach there that we need to fix. And so anything I can do to go back to our pharmacy leaders to say, we need to look at this differently. I'd love your input. It could be now or later.
Yes, go ahead, Chris.
I'm not sure if people are aware of is it the OECD survey that has been done in other countries? And they've already come up with new questions for HCAHPS. That is why don't we look at those that have already been validated? One of them is, did the healthcare professional you consulted know important information about your medical history? I mean, these are more relevant questions than did you wash your hands? This would change, to me, it makes it more patient-centered. It would change outcomes if you start asking more relevant questions that are for the patient.
Agreed. And thoughts on, so trying to pull all those threads together. So, you know, part of, and I think this was brought up, Henry may have brought it up, but, you know, there's many different parts, there are many different players in the ecosystem that have to surround a patient as they go through their care journey, right? And so Al's highlighting one that we traditionally haven't paid as much attention to vis-a-vis this conversation that we're having. Any thoughts on how we actually start to incorporate more of the critical role of the larger ecosystem around this? Sorry, didn't mean to ask that question. That's a hard one. I'm blaming Al on that one. That wasn't me. I'm just channeling. No, maybe that's just something to contemplate. But it's, you know, it's a critical. You want us to get to the point where, you know, we're asking some of the hard questions, and we're trying to really dig into where there's gaps. I think we're there. And having these conversations.
Yeah, I think maybe the basic premise is the difference between patient-centered and consumer-centered, and being willing to understand and accept that term. You know, even if you think of Amazon, right? All of you have now seen when you buy something, you know, next thing you're getting suggestions that people who bought this also bought this because they needed it. You don't buy a vacuum cleaner without bags or the filters. That is not there. The data's there, but we're not enabling and empowering our providers, pharmacists, doctors, nurses, everyone with that kind of information. We're giving percent top box.
Provocative. Come on, go ahead.
I wanted to double click on Chris's comment about narrative comments, really as also insight and signals into equitable and respectful care. Adding to that also are things like portal messages. As Henry mentioned, I mean, the data is there, right? The data is there. We just sort of need to use it. The point that I wanted to raise, which was also brought up in our small group, is there's a lot of discussion on how, you know, and what modalities to ascertain experience or satisfaction. But I would like to see some study regarding the mechanisms to best close the loop with patients and communities, because if they are so generous as to give us feedback or let us shadow them or let us, you know, join a focus group, health delivery organizations need to close the loop with them on the impact that their generous feedback or their generous responses made, whether it's to improve outcomes or, you know, their favorable comment was shared with a provider and that made their day, right? Like these are the things that we really need to sort of study more broadly if we want to move the needle.
Cincy.
So first of all, I want to really glad Kamala you mentioned what you mentioned, because At the end of the day, when you're thinking about research and you're not thinking about the closing the loop and how that actually affects you and your community, it's an extractive enterprise, right? And that's one of the challenges that we need to make sure that we aren't just kind of popping into a situation, which for a lot of us may have been traumatizing, difficult, not resolved yet, and then asking these questions and, you know, what's going to come out of it, right? I'm really blown away by the idea that healthcare can delight the customer. I have to say, you really made my day with that. Because, you know, when I go into a healthcare experience, when I go into healthcare experience or often what I end up doing is helping others through healthcare experiences in the family, you know, delight is not the goal. Like being treated with dignity and hopefully not dying or being disabled, that is the goal. And maybe that is very representative of like the kind of people and the communities that I am working with, you know, women of color, people who, you know, again, like almost died doing, like I've had two experiences in my own life as a health policy nerd with, you know, a JD and from fancy schools and Cadillac insurance, thanks to being in a union, you know, all of these things. And still it didn't stop me from almost dying twice. And did anybody ever come back to ask me from those experiences, what happened? Where did it go wrong? Did anybody even, considering that they were traumatic experiences, even follow up with like, do you need PTSD treatment or any kind of screening on mental health? None of that. On the contrary, when I asked my OB, why did I end up 16 days in the hospital, septic, 3 surgeries and almost died? His answer was, must have been the dirt that I sprinkled into your wound. And so that is, when we're talking about delight, you know, I think that at least for some sectors of the population, what we really are talking about, what do we do to not maim and kill people? And I'm sorry to make it so extreme, but doing research in an office and you looking at all these numbers and, you know, regression analyses, like that's all extremely important. And as an advocate, I know that when I go to an agency or to a congressperson or to a CEO, I need to have the data, but we are living in a world where we know that data is not enough. And that you have to be able to connect it to real life experiences in order to change the policies and the systems that continue to reify and solidify these inequities that our communities continue to struggle with. And so my question, I mean, one of the things that we discussed in our small group was that a lot of the challenges happen in the in-betweens, right? Like being discharged too early to nothing, you know, and your drugs not being ready for 3 days, or, you know, the story that were told early in the morning about the transitions in care. And I don't know that we have a unit to give a survey to in those interstices, right? And so how do we get to that? Not just closing the loop from data, from giving information and feedback back to the patient, but how do we close all those gaps, which is where the really bad stuff happens, and where patients and patient advocates and their families don't even know what to ask because it's a completely unknown territory for them. Even people like, you know, super educated, et cetera, won't know always what to ask. Let alone be able to advocate then for the thing that they need, let alone then fight with the insurance company so that you get the thing that you need, let alone then trying to figure out your bill because it's not understandable, all of these issues. So I get a little bit agitated about these things, but it is the patient voice that will be messy, right? It's not going to be in these necessarily categories, but we have to embrace the messiness because that is how we get the change and drive down into what are the systems that need to be changed, not just giving people another, you know, unconscious bias training, or it's because it doesn't matter. The intentions that we heard earlier, that people go into these fields because they have good intentions, but they're in a system that chews them up in a way that they can't fulfill their good intentions.
Yeah, you highlighted several things there, but one of the conundrums that you highlighted is this idea that, how do we talk about patient experiences? There's a component of patient experience that's the quality of the care delivered. How do we measure our consumers' perception of the quality that they received when they're not sure how to rate or judge quality? So that's a bit of it's a little circular there, right? So that's a challenge that is also on the table here. Joe, I think you're next up.
Thank you. I apologize. I have a little bit of noise in the background. So if it's too noisy, please just let me know. So I think my comments are very similar to those that have already gone forward, but I just thought I would still bring them forth. I just want to say also that I enjoyed all the speakers. And I was wondering, Dr. Winch Maldonado, with the studies that you did, was there any qualitative data along with that? So with all the different surveys at the different levels, was there any qualitative data, kind of like what we're talking about now, like the stories and those kinds of things? And then I was also wondering, was it linked to any like outcomes data as well?
Yeah, those are great questions. Like everything else, you're always limited by the funding you get. So it was all, we did do qualitative components, but it was more in the development, particularly the CAPS, cultural competence item set, where, we validated them from, a patient perspective. But as far as the actual studies, they were focused on kind of more quantitative survey data collection. And in both cases, it was focused on CAPS. So no other outcomes. It would be great, to collect similar data, through other studies. But yeah, at least in the studies that we did, it was limited to those aspects.
Thank you. As per previous comments, I think it would be really powerful to see how those stories really bring to light the results of some of those perceptions.
Absolutely, I agree. Yes, thank you.
Caroline.
Thank you. And thank you again for those presentations. It's very helpful to learn. I have a basic question, and it's one from experience using the CAPS from the health plan setting. I have plenty of experience from the provider setting as well. And as a provider, often felt frustrated that I was being measured on how the front desk greeted the staff and so on, that, the experience wasn't something in a system that the provider necessarily has the ability to control, but yet, the whole clinic was being measured as such. And so there were often times where, as a provider, I would doubt the validity. As a health plan, during the CAP surveys in a Medicaid plan, we had incredible challenges, even ever meeting the denominator number, because of very challenging to reach members. And so I'm asking a question about the validity of surveys in settings where the members are very challenging to reach, and those that you do may have some inherent bias because they are available compared to those who just simply are unable to be reached or won't participate. So I'm trying to learn and would really love to hear from you all what that, is that a valid concern that these samples may be biased? As an individual, I write if something is really great and I write if something is really terrible, but all the stuff that's good and fine and normal in between, I don't think about. And so that also makes me concerned sometimes. Is there an inherent bias in the surveys? So I'd love to hear the expert opinions.
Yeah, that's a great question. I did some research a few years ago with safety net providers,
and the challenges they faced in connecting with and surveying their patients. And I can orient you to the findings from that. That was sponsored by the California Healthcare Foundation, so it's publicly available. I think to understand, and it resonates, that one wants to be looking at data that is representative of the patient population, and that the concern is, those who respond, are they different from those who did? And that's a deeper conversation, kind of specific to the data that you're seeing. But there are things you can do with those more challenging populations to improve their response to surveys. We've seen things like tablet-based administration that's happening upon exit. We've seen sending people home with a survey. We've seen efforts to make sure that you have good contact information for patients. But I think something that's critical that I heard people bring up here is that patients have to see some kind of results from giving that feedback. So if somebody gets a follow-up phone call, or someone reaches out because they saw a report of a problem or wanted to know what happened, those are things that I think are very important to helping patients understand, oh, someone does look at this information, someone does act upon it. I'm not just hollering into an abyss.
I appreciate that. I think one of the challenges in the Medicaid managed care space is that the states typically at a certain time of year say this is CAP survey time of year, and all the health plans do whatever they can to try to find individuals and bring them into the survey, including the use of tablets and that sort of thing out in the community if we can find the members. But some of the tactics that we talked about today in that large survey methodology that's being required are a little bit more challenging to get to. Thank you.
Thank you. Maria, you're up.
Yeah, so I'm going to say something a little bit maybe controversial, maybe not for some of you, but I do think we should keep in mind that healthcare is different. There's never going to be a way to delight me when I have to go in for a cervical exam or a pap smear. Like, that's not a reasonable expectation, I think. And somewhat to that point, we've kind of had to dial back the issues related to patient experience and kind of pain management, with the acknowledgement that kind of rating pain management may have contributed to the opioid epidemic. So I just want to point out that I think this idea of kind of patient experience and delight, we need to make a distinction about where we should expect this, and where we can push on this and improve the experience, and where maybe this is not something we should expect. So just wanted to add that to the conversation.
Thank you. Andy.
I'm wondering to the degree our patient experience, patient satisfaction still is very episodic based, very kind of moment in time. It doesn't really measure lived experience with the healthcare system. And setting aside all the problems with response rates that you talked about, wondering if we should think about it more as anything else we manage at a community-based or a population-based measure. Should we be measuring this over periods of time with people who are willing to participate with us? This raises a whole raft of other methodologic issues, I realize, but I do worry that we're looking at satisfaction as the piecework of medicine rather than the lived experience of the patients coming through the health system. And the methodologies that you need to do that are very different, require different partnerships, and maybe a place AHRQ could really move the ball forward. Again, and I'll leave it there because I realize there's left like 10 years of research in front of me with that comment, but it really feels like an opportunity.
Right. No, and I think I had heard earlier a couple things here that may be related that you're saying, Andy, or maybe they're different. But one is measuring an individual consumer's journey. The other is measuring at some community level of some sort their experience with the healthcare system. Those are they have different methodological challenges. So those are kind of options to think about and consider and agree that AHRQ could play a role in framing up what that would look like. David Schmitz.
Thank you for the opportunity to make a brief follow-up, and it'll sound like it was set up to respond to you, Andy, but I really wanted to just share, I know much of what I've been talking about is my rural or remote-based lived experience, but I think there are really a couple of examples in doing research in those sorts of communities that are lending themselves towards methodology. We talked about the importance of closing the loop with regard to feedback and information is given. And I think a lot of this comes down to transparent, accountable care. And part of what happens with transparent, accountable care is you have continuity of care, and you also have feedback that's legitimate and personalized. And so in my small town, nobody looked in the phone book to see which family physician they were going to go see, or whether or not they were going to go see the only surgeon that we had in town. They asked their friends, their coworkers, their family members. And we all knew, well, we were taking care of multiple generations of families. When the baby was delivered, you'd find out who the rest of your patients, how they were connected to each other. I mean, it was just a closed system, and I think that the other thing is that when we were on call every fourth night or every fourth weekend, if I discharged a patient and that patient came back, there was a 1 in 4 chance that I was the person who's going to readmit that patient. So I guess what I'm trying to say is rural is not the only example of that. I think with federally qualified health centers, urban environments, there are places to develop methodology and potentially pilot that where we see longstanding continuity of care. We see a population where we can study population health and the population's receiving healthcare and how that's integrated into a relatively isolatable for study purposes, community of other factors. And I think that would be a great opportunity for some salient research questions and possibly some pilot examples of how to deliver healthcare better.
Yeah, as I've been listening to the conversation, much of which was talked about earlier today in our small group, I'm thinking about a couple of things, Cincy, based on your comments and others, that I wonder if we need to get a consumer/patient defined definition of both quality and value, because the way the quality and value have been defined from the healthcare system, healthcare provider perspective may be and probably is considerably different than the way the consumer or patient would define value, and would probably depend on their circumstances. So I'm also wondering about how we might think about evaluating patient consumer experience in the context of that experience. For example, if I'm a very healthy, well person who shows up once a year for my physical, my patient experience is going to be very different than somebody that has chronic comorbidities that requires care coordination and transitions and all of those sorts of things over time. And so how do we think about evaluating differently based on context and circumstances and interactions with the healthcare team and healthcare system? And the last thing, I think it's incredibly important, as others have said, that we give patients and consumers an opportunity to expand on comments they may have given us in a survey. But I would also challenge us all to remember that trust in the fear of retaliation or different treatment based on me giving you my name for you to call me and get more feedback may or may not be comfortable, depending on how comfortable I feel within the healthcare system. But to David's point, if I've got a relationship with you and you ask me right there, what did we do well? What did we not do well? I may be more likely to tell you.
Great points. And I think this trust theme, I think, is going to continue because it touches on so many different aspects of what we're trying to do across the board. I thought I saw someone. Yeah, I thought I saw Gina. Did you drop off? Yeah.
I'll expand a little bit about what Kathy said, because I was going to go there in that people's experiences are different. So the point when they're seeking care for different reasons on different levels. So they have different levels of expectations going into it. And that gap of what their expectation is and what experience was actually delivered is really what we need to understand better if we're going to move the needle and make improvements, is we need to understand what lies in between. And also the fact that, what matters most to the consumers, just pointing out what Chris had said, that it's what matters, that it's different for a lot of people. I think that that's the other key. Like, you go in with your own goals. Are those goals being considered when you're asking questions like that? Because, if I'm looking at the questionnaire, I'm going to say these questions don't matter. This is really what I want to point out. And oftentimes we'll get survey responses that are practically blank, but then the comments are filled in, and this is really what they wanted to say. So we have to find a way to incorporate that into a standardized measurement so that we can get that feedback and close the loop, bring it back to those that can take action and, improve the overall experience.
Yeah, Krista has mentioned this before. She actually earlier, both in her earlier comments as well as this, in the pre-work this morning, around this idea of narrative, the narrative component of the experience feedback, and how do you incorporate that narrative into your understanding of the experience and that was delivered. Liz, you're up.
I just have a couple of comments in listening to everyone's incredibly rich comments. I think some of what are the core expectations for patients are not measured through patient surveys, but are measured through safety measures. So, and if we have a limited amount of research dollars, should we be thinking about, if we had unlimited amount, then we wouldn't have to make priorities kinds of decisions, but things like diagnostic accuracy, diagnostic delays, medication safety, med rec errors, those sorts of things. Those are the big ticket safety harm kinds of things, right? And we don't really even have good standardized measures. So continuing to spend money on patient satisfaction experience surveys, if we had unlimited resources, fine, but maybe we should challenge ourselves to put more into those other really core measures of patient experience, the key things that patients want from us as providers, which is the right diagnosis, free from harm, and et cetera, et cetera. And then the other thing, if we have to make decisions, is that continuing to measure the same kinds of things. Yes, we're going to evolve our surveys, maybe get more narratives, maybe look at other aspects like the digital experience. But we also should challenge ourselves to put more research dollars into what we know works to improve. What are the 3 or 4 things that should be, national patient experience goals or standards of care that just get rolled out, so we can push more on the improvement. And because the surveys, we can really get bogged down and we don't have unlimited resources. So just a push to think about other measures that really matter to patients and to push on research that actually shows in a feasible, scalable way, we can make a difference.
Yeah, great points. I would even push. So even if we had unlimited resources, I think we should still question some of the things that we do. Right. So we talk, we talk about survey fatigue, for example. But there's this other, and we talked about this a little bit this morning. David Ash is an expert in the space, which is we haven't brought into this conversation, which is what are the unintended consequences of asking certain questions? Right. So you think about, we all, like, everyone knows what's on HCAPs in the hospital, the folks who actually ultimately are going to be asked to address them. So what might they not be doing because they're trying to make sure that they're getting those scores, those top box scores on the HCAP survey? What are we missing? Right. So what are the unintended consequences of some of this measurement? Neil, you're up.
Yeah, great conversation, and I'm thinking about what do we have to show for all of it? So, Henry, you started off the conversation talking about the history of CAPS and how long it's been around. And, I'm wondering, to Liz's point, what have we learned in terms of what works and how to improve the patient experience? But also to think about, as we move forward with measurement, how are we going to evaluate the success? We're not measuring for measurement's sake. We're measuring to improve the patient experience. And I think we need to have some metrics developed around, is the patient experience improving? Or where do we see improvement? Are we seeing, even with the publication of provider level information, are we seeing some migration towards the higher performers? Is any of this having an impact on consumers or on providers? And if it's not, then why are we doing it all?
Great questions. Not easy answers, but great questions. David Atkins.
Yeah, I think following up on those last two questions, I mean, so one thing would be to sort of say, where do we think we have the greatest opportunity to improve patient experience? I mean, it's like our other clinical measures that we ought to focus our measures on places where we know there are gaps, and measures that will actually help us close those gaps. So I think I'm echoing both of your comments that rather than trying to tweak the measures we have, we ought to say, have we used the ones that we have now to their best advantage? And if not, how could we? And how would we show that measuring all this is actually linked to changes that would improve those measures?
Yeah, I see. I'm gonna again take a little chair's privilege here and call on Tom. Right. So, we're having these conversations around in this setting around understanding, let's call it understanding our consumers. I'm going to use Henry's word here. Understanding our consumers from a health policy perspective. How much is this part of the conversation? Do you have any additional insights or even more provocative questions that we should be considering here?
Well, I think Neil raised a good point. My understanding of a lot of the research is that when consumers have been presented with this kind of information to be choosing health plans or choosing providers, it's not clear that it makes a huge difference. In a lot of cases, people had other sources of information already, and so the additional benefit was small. And to Mirai's point, it's a very different kind of consumer choice problem than in choosing an airline, choosing a car mechanic. So yeah, I think there is the open question of what has been the impact of this. And I guess I would just also underscore Liz's points about we do have other measures that patients care about and that are clinically validated. So that's maybe an important thing to emphasize in terms of measuring quality, measuring patient experience.
Thank you. Joe, you're back up.
Thank you. I appreciate all of the comments. I was just thinking, we talk a lot about team care and how team-based care can improve outcomes with the patient being a part of that team. And I wonder if some of the same drivers of dissatisfaction or lack of a positive patient experience are the same drivers that drive lack of physician wellness or nursing wellness or whatever. Like, I wonder if there's a lot of overlap and if there's an opportunity to sort of look at the places of overlap and look at a team approach to improving the patient experience, where we kind of look, and it's kind of like the quintuple aim, but really just focusing on, is there not even just the diet of the provider and the patient, but just the whole team? Like, is there a way to look at what some of those overlapping drivers are to improve it as a team and not just from an individual perspective? I suspect that some of those drivers are the same.
Yeah, I suspect you're right. So Les, you popped that up, so I'm gonna pause my comments and go to you.
Could I just make one more comment? as I'm eager to move to action in general in life. So the one thing I just wanted to share with everybody that I'm sure you're all aware of, the What Matters to You campaign. And, you know, I don't know that we have evidence to suggest that if we as providers ask every patient every time in a visit, whether it's emergency department or ambulatory or whatever, saying, you know, you're here today in our practice, and I'd like to know before you get started, what's most important to you, what matters to you, and act on it. I was so moved by hearing about that tagline and the power of it that I started to do it in my own primary care practice. I ask my patients when they come in for their annual exam that I tell them, look, I've got all these things I have to do before I start. What do you want to get out of it today? So there's something important. Now, sometimes that ends up in a place that causes me to have them come back for more or not get everything done. But I do think it's patient focused. Could we study that? Could we study, maybe it has been studied, some simple solutions along the lines of national patient safety goals, 2 patient identifiers, labeling pap smears in front of the patient. And maybe there is no evidence to suggest a simple tactic like that would work. Maybe it's just common sense that it's a good thing to consider. But I'd love us to move into the realm of solutions.
It's a really great question and fascinating for me experience that was unanticipated. So we were implementing a virtual scribe program. Okay. And in order for the scribe to really capture the entirety of the visit, you actually had to verbalize everything that was happening. So you could have a regular conversation with the patient and talk about, you know, their reason for being there and what you're going to do. But when you did the physical exam, you have to actually say what you're finding, right? Because the scribe can't pick up something that you're not saying, right? So you had to say, you know, this is a regular rate and rhythm. I hear no murmurs or or whatever it is. You had to actually go through the exam and verbalize it. Amazing that the patients love that. When you actually tell them what you're finding when you're listening to them and examining them. So it's really fascinating. Let's go to Henry.
Thanks, Armando. Just a couple of comments. I think when Liz mentions diagnostic delay, diagnostic accuracy, and free from harm, those are sort of the table stakes. Those are the foundational components that people expect from their provider when they're having their visit, surgery, or procedure. And I also want to sort of touch on Marilee's comment that, no, I can't make heart surgery delightful. It's going to hurt, and the recovery is going to be several weeks. But there are components that I don't think we can ignore, which is the components of hospitality and service outside of healthcare are relevant. And I think the components of navigation, access, and coordination, that is ripe for virtual, asynchronous, digital, large learning models, generative AI, all the things that need to be done better, that our consumers probably interact more with than having heart surgery or having a complication. And those things are very broken for most people when they have to figure out navigation, access, and coordination. Healthcare in reality is one of the few things we schedule or ask for that we have to call someone. Most other things we probably go on the web or on our phone and schedule it at a time we want to go.
So
Just a few comments to go off Liz, the What Matters to You movement. You asked if it was just common sense or research. That's what I always ask all my clients is, what is your goal? What do you want? What do you want from me? And they'll tell you, they know what they want, but if you don't ask, you don't know. And there's a lot of assuming that goes on in healthcare. And number 2, Bob started the meeting off talking about how patient safety, it's been 22 years since this movement. And in my opinion, working in the bowels of the hospital is the worst I've ever seen it. And it's time to shake things up and do something different. And Liz, I like what you said. We need to focus more on not the patient so much experience, but patient safety, because that is what's important to them. And you know, let's dive into that, act now. Let's do something. Like, we can't wait 5 more years for this. And Kathy was talking about trust. Half my clients will call and they would rather go back and be harmed by the doctor than tell. Because they always tell me, I had a client that was mistreated. The doctor put his hand in his face. He was dismissed, didn't even address the symptoms. And I said, I need to address this. And he goes, no, they'll treat me worse if I go back. So just don't say anything. And he was willing to go back to a doctor just so he wasn't treated even worse the first time.
It's so Caroline, I'll give you a minute, and then I wanted to give Bob a chance to wrap up. We've got 2 minutes left in this topic. So Caroline, go for it.
Quick comment about this in thinking of money follows the practice. And so, one, how much are we spending nationally in these areas that if we pulled back what we know doesn't work and redeployed it to something that might, just, globally, to think about that as an agency. The second thing is, I would be really curious what the effect of private equity is going to be on patient satisfaction. We know it's resulted in a lot of provider dissatisfaction. I can't help but think that would roll out to patient satisfaction. So I would encourage the researchers to look at that as a potential variable going forward. Thank you.
Thank you. Bob, bring us home.
First of all, thanks very much for giving us great food for thought, for thinking about how we can think about moving forward. Some of your suggestions are actually actionable right now because while we have the CAP survey, we also hold other databases and other survey instruments where we're trying to gain a better understanding of people's use of health services. And there are, I think, opportunities to augment some of those surveys to deal with some of the issues that you've raised that don't necessarily fit within the CAPS framework. So I think we have a lot to think about, thanks to your suggestions, your discussion. And I certainly know that on the patient safety side of things, we have a National Alliance for Patient Safety that we're trying to co-create with healthcare systems and patients and other stakeholders. That is in response to the truly epidemic of patient safety events that have occurred in our healthcare system, with approximately 1 in 4 people who are hospitalized experiencing some type of patient safety event. That's a consistent number over a long period of time. But the hopeful part is our AHRQ staff illustrated that over the course of the last couple of decades, where we've focused attention and used evidence-based interventions, we were able to make slow but steady progress in reducing patient safety events. We need more of that evidence. And thanks to you, you help us identify areas where we need to really sort of prioritize and invest our limited resources where we can have the biggest bang for the buck. So I want to thank you for helping us figure those out, for helping us see those, because those of us who are often here in the Washington, D.C. area don't get to experience firsthand what you experience in your own home communities. And as I repeat to my staff, all healthcare is local. And unfortunately, we can't be everywhere, but you can be, because we bring you together and you give us that opportunity to understand what's going on elsewhere.
Thanks, Bob. And yeah, thanks for being here. Thank you to our presenters. Really great a way to set up a really robust conversation with lots of questions, but potentially even some early actionable opportunities as well. Let's jump into public comment. We do have a few public comments that got in by the deadline. So we'll start with MyFam, President and CEO of Institute for Exceptional Care.
Sorry, can you hear me now?
Yep, you're up.
Thanks.
Thanks very much for the opportunity to comment, and I appreciate the next discussion. I'm coming to you as leader of a nonprofit advocacy organization focused on making healthcare better and safer for people with neurodevelopmental disabilities, but also as a former CMS official and a former NAC member and a clinician. And I think I'm going to have to throw my planned comments out the window to just respond a little bit to the conversation that I heard. I just want to underscore the importance of taking this outcomes-oriented, patient, person-centered, goal-setting approach to measuring quality of care in healthcare and all outcomes in healthcare, really. When IEC engages multiple stakeholders from both healthcare and disability worlds in trying to define outcomes that matter for people with IDD. It is a deliberate process, and it was completely manageable by a small organization with a staff of 7. I have a hard time believing that a federal agency and or large health systems cannot accomplish the same on a daily basis. It merely requires learning some basic skills about communication support and being open-minded about eliciting and leveraging the genius of lived experience. And from that perspective, I also want to close the loop on patient safety versus quality or patient experience of care. I hope that that's not going to be conceived of as at AHRQ as an either or proposition. I think that they are all really critical to understand and to track in an actionable way. And I want to underscore that from the perspective of someone who has had to negotiate provider payment contracts and track provider performance and hold providers accountable for performance, CAHPS as in its current state has actually become a hindrance and a source of potential harm. Precisely because it has been so successful and established as an industry standard, it stands in the way of moving clinicians and provider organizations off onto more meaningful measurements. And what I mean by harm is, I don't mean to sound hyperbolic, but I look around at the state of health in America and healthcare, and I ask myself, is it really the case that all the mistrust in healthcare we have witnessed since the pandemic, since before the pandemic, was merely a result of political brouhaha? I don't believe it was. I believe that it landed, those politics landed on ground that had been tilled through decades of healthcare not listening to the people who need to use it and need to get supports from it. That mistrust is really deeply embedded. And without understanding that, without starting to repair it by going back to the people whom we're trying to serve and asking them, what does good experience mean to you? Rather than making assumptions that what they mean is, by good experience is good diagnostics and reasonable treatments. I can tell you that when we elicited what health outcomes matter most to people with neurodevelopmental disabilities, they did not mention medication anywhere other than that they did not want it to be the first reflexive response to a mental health crisis. They did not mention diagnostics anywhere. What they talked about was a provider listening to them, understanding their goals, addressing their needs, and helping them to navigate the system. I can go on, but
Maya, I'm sorry, your time is up for public comment. We appreciate your comments and all that you have done and do for our patients. Thank you.
Thank you.
Next up on public comment is Samantha Sheridan, Institute for Exceptional Care.
Can Samantha access the Zoom?
Hi, sorry about that. Took a little coordination. Let me pull up my comments.
Yes, you have 3 minutes.
Sorry, I'm sorry. I'm just trying to find my comments that I just lost coming on as a panelist. Sugar. Okay, sorry. So I am Samantha Sheridan. I just actually recently retired from working with my FOM at the Institute for Exceptional Care. But I have been working on CAPS since 1995. As Julie Brown knows, I was the project director for 15 years for the contract that AHRQ supports, lets to support the consortium. But after that time, I did move to CMS and I worked at the Center for Medicare and Medicaid Innovation, overseeing payment coordination and payer coordination and CAPS for CPC Classic, CPC Plus, and Primary Care First. So over the course of 7 years, I oversaw the collection of millions of CAPS surveys for the purpose of payment adjustment. And I know, we all know that CAPS was initially developed for public reporting on public choice, as everyone talked about. But in fact, it is used by alternative payment models. So I'm going to be making my comments in my role as a payer overseeing the patient experience portion of these calculations for payment adjustments, which we used CAPS clinician and group with some PCMH items. Most of the most of the primary care now in the country is by CMS, and commercial payers are not covered through strictly fee for service. It's a combination of full capitation and partial capitation with extensive incentives and bonus payments. Because these arrangements support innovative comprehensive care, often this is not documented in claims or in encounters. So you can't see all the interactions, which makes patient experience of care even more important. But as we've all talked about, the content of that survey hasn't kept up with the relationship-based longitudinal care, and that is reflected in concerns from the practices providers and the payers. So this includes things we've talked about: planned care for chronic conditions, medication management, self-care, consistent, high-quality, asynchronous communication, follow-up after all hospitalizations and specialist care, social determinants, sourcing, and screening. I could go on. And most of the practices are under high-risk arrangements, or where a significant portion of their scores of their reimbursement come from quality measure calculations, of which CAPS is a huge and enormous part. Yet the practices,
I'm sorry, your time is up.
they have virtually no control over the outcomes. Sorry. I had a lot more to say. I thought I was talking fast enough. Okay.
Samantha, appreciate you. Next up for public comment is Alicia Berkmeyer, Arkansas Blue Cross Blue Shield. Alicia, you have 3 minutes.
Good afternoon, and thank you for allowing me the opportunity to share a few thoughts and comments about the CAPS survey. Looking at this, I strongly confirm that patient feedback is very important. As I look and follow with Samantha a little bit, my experience began with the CAPS in the early days of the value programs of the comprehensive primary care, moving into CPC Plus, and also into the primary care first. Through this experience, I have certainly learned that tool being used in the value programs, it's very important for us to really look at that. And I question some of the opportunities and meaningfulness of the current environment to really support the patients and the providers. You know, going back, if any of you as a parent, you really understand very quickly that the lessons learned from our children, we have to react very quickly and close to that behavior. And so as close to possible as that action, be it a positive reinforcement or a negative reinforcement, kind of working with them. And one of those challenges that I certainly see with the CAPS today is that the behavior and the response is not close enough due to the timeliness of it. Providers are needing a quicker response to really make some performance and changes and opportunities. And I think also the length of the time from the providers and the patients sometimes understanding the behavior. So there's also the bias, which I think you're all familiar with and discussed on here today, about how do we make changes, improve that care for families and patients, and truly looking at the length and the opportunity to improve that real-time response to support both the patients and the providers. One of the other concerns really is an understanding and remembering what the patient received and the terminology for those patients to understand. I love the comments earlier about truly looking at the patient, getting that patient impact, and putting the patient at the center of this care and the improvement of the care that is needed. The variation of the score creates some challenges in really helping address what the patients want and need. the cost of administration supporting some of the rural practices that I've here in Arkansas really struggle with that, some of that support. You know, today we can actually take our pets to the vet or our cars to the shop and we get a quicker response and feedback opportunity. And I really think we can do that in healthcare as well. I just really wanted to ask you to consider today that we are truly looking at a better, meaningful way to address real-time performance and tools and opportunities to make an actionable difference in improving healthcare and truly the experience of patients out there. I appreciate the opportunity and your time today and the consideration of this input and look forward to more opportunities to collaborate on ways that we truly can make a difference in healthcare and get the patient's voice to help the providers deliver better care. Thank you.
Thank you for your comment. Next up is Lovett Olatunji, President and CEO of BioHealth Care Management. 3 minutes.
Lovett, please unmute so you can talk.
Hello. Hello.
Yes, you're on. You have 3 minutes for your public comment.
Thank you. It's a pleasure being on, having the opportunity to actually speak. This is really last minute for me, but I really wanted to make sure that that it was known that Florida, I'm coming from a state where there's I see a lot of issues and concerns with patients, discharge planning, and so on and so forth. And so one of the things that I really wanted to touch on was just how could we better serve the patients in the state of Florida, specifically Orlando and the 4 counties surrounding Orlando, Orange County. And I wanted to know how we can work together to develop relationships within the community, because a lot of the patients that are discharged home or to a skilled nursing facility do not have adequate resources for them to be either independent at home or at their facility. There's a lot of resources, a lot of gaps, and a lot of patients who have expressed concerns with getting long-term care and so on and so forth. And so one of the things that I would like to see going forward is the opportunity to develop, have research more specific to a certain group in terms of either oncology or neurology, so that patients can kind of get what it is that they need in the community. And that's pretty much all that I have to say for today. And I thank you for the opportunity, and I hope in the near future that we do see some changes within Florida, because there are some very important needs that need to be met. And I think even if Florida was the forefront to a lot of the researches that could be done, that would be a great opportunity for the state. And that's all I have to say for today.
Thank you for your comment. Next up is Beth Daly-Ullum, Patients for Patient Safety. Beth, you have 3 minutes.
Hi, thanks so much for having me. On behalf of Patients for Patient Safety, which is a patient-led organization of patients and families and advocates organized under a chapter of the WHO's Global Network of Patients for Patient Safety. I'm here today because I lost my son to medical error. And one of the most frustrating things to me was not being able to contribute to the body of knowledge and the event reporting when that happened. And so one of the greatest threats that we believe exists to patient safety is the lack of appropriate patient-reported data to understand the patient experience of safety, as well as perceptions of safety while receiving care. And I really think that there should be more opportunities for patients to contribute to that data set so that that can be cross-integrated with the other information that's coming into the health system. Patient-reported experience of safety could really be an invaluable way to have look at patient safety more holistically and identify opportunities for improvement. We also support more transparent responses to harm around harm events. And if patients are helping identify harm events that they experienced that might not have been reported in the incident system of the hospital or nursing home or care facility, it's another source of data that's important to integrate into how we look at harm. PFPS US proposes the redesign of the CAPS to be more oriented around patient safety to issues that matter most to patients and families. Using the OECD's patient-reported experiences and safety global initiative that exists, which uses a validated survey set of questions that were developed with patients. PFPS US calls for partnership and urgency to address the integration of patient perspectives of their own experience of safe care and harm. We look forward to working with AHRQ and the HHS leadership to make CAPS more patient-centered and responsive to the harm concerns of patients. Thank you.
Thank you for your comment. That wraps up public comment for this meeting. Let's move to the wrap up period here. So we're gonna pop down a couple slides here, and we're actually gonna and you're gonna use my wrap up time to chat about our pre-session work. Hope you guys have had all meeting to prepare to present out on your groups. So I hope we're very well prepared. Each group will have 3 minutes to report out on what your discussion was. Can we move to the question slide, please? Yes. Yes. Okay. Here were the questions that were in the pre-session discussion. You can see them on the slide here. So let's start with the first group. I'm sorry. Let's start with the first group that was on the health system discussion. So not our group, the other group that was on the health system discussion. Who was the presenter for that group? All right, I'll go for it.
All right. Thank you, Mr. Chair. So we had a lot of interesting conversation. It kind of digressed a little bit based off of just measurement tools and what have you. But to go through it really quickly to share some of the high points. The focus was really on inverse relationship between all of the quality measures and patient satisfaction surveys. Why we're bottom of the barrel. Question was asked was why we're bottom of the barrel practicing MDs getting such great survey results, and if so, it makes you highly skeptical of the value of the experience and the patient satisfaction measures. And sometimes these surveys will look at being counterproductive to what we're trying to do with improving healthcare. Maybe there's too much emphasis being placed on patient experience measures and distracting from clinical practice. As far as the patient experience measurement piece, there was comments about how it's been made easier. It used to be a paper, but now it's gone to electronic, and some even mentioned during the sessions today about going to a tablet immediately after you've seen your provider. A lot of discussion around asking patients to comment on what we think we are doing well. And that may be negative in comparison to what the patient wants or thinks they need, which is something that Dr. Moore mentioned just the last session. And then other things that were being looked at, we're looking at continuous surveys, but the response rates to those continuous surveys, not just to a specific population, but to everyone, we're getting response rates that were lower. And so how do we address that? Consumer has their mind made up as to a good or bad experience, leading to a lot of bias in these surveys. And comments focus in some of these, when you read through the comments, are focused on things outside of healthcare being provided, such as facilities, parking, or attribution of responsibility. And so just how do we hone in back to the true origination of these surveys? And then patient experience comments, questions need to be pitched to the appropriate responsible individuals, because sometimes they may not impact the provider that's providing the healthcare. But just make sure that we don't discard these comments, but utilize them with caution. As it pertains to consumer and patient satisfaction measurement tools, most in our group use a standard set of measurements to use HCAHPS. There's a Press-Ganey survey, the pros and the proms, the GCAHPS, and then and those were the main ones that were being used as far as measurement tools. And then how does the health system use the information that's collected? A lot of it was used for symptom scores to determine treatments and state of patient. Individual provider ratings are beginning to emerge, and so it's something to start seeing. If if that provider doesn't have 5 stars, am I going to go to that individual? And then we mentioned out challenges, intrinsic biasness in the health population being served, and how that's a challenge because of who these surveys are necessarily going to, maybe not necessarily going to appropriate people. And then also another challenge is a patient journey and the efficiency. More of some of the pain points are being missed or not necessarily being captured. And then attribution issues as to was it really for the nurse, for the doctor, for the pharmacist, or for some other staff that was involved? And team, did I miss anything else? All right.
Good job. You're only 30 seconds over. Awesome. Great, great work. Kamal, you gotta meet that 3 minutes.
I'm ready. And much was already discussed. So I'm just going to pull out a few highlights and just acknowledge that our perspective comes from, we all have an interest in healthcare quality. That's why we're here. And we're also patients. And so we have sort of a blended approach to the questions. I'm sorry, I'm struggling with asthma today. Our overall sentiment is that patient and community voice is essential to quality care, and that the definition of what quality should be sort of defined together. And so to that end, the tools have some usefulness and some limitations. As was mentioned by NAC member Joe, some of the issues around sort of patient experience possibly and likely overlap with workforce wellness. And so how can transparent sharing of comments, design of surveys promote both? We also recognize that sometimes the survey results, or I should say tool results, are part of evaluations, and we recommend that they not be the sole element of evaluation, but rather part of a more holistic review. We cannot get away from the fact that the patient experience measurements are tied to reputation as well as remuneration. And so we acknowledge that healthcare delivery entities really need both training and guidance on sort of what comprises these measures, especially frontline folks, as well as support and resources. If we are sort of talking about expanding to narrative and things of that nature, it's important to sort of note that. And so some tangible next steps are, again, to double click on this idea of inclusion of more narrative comments as a way of, stories and narrative feedback have tremendous power and value, and again, can provide signals into respectful and equitable care. Patients now have more input into their charts, right, as a result of the CARES Act and other changes to HIPAA, et cetera. So how do we sort of harness that and understand the patient experience from sort of the vantage point of the portal itself? I want to double click on Edmana's point about better understanding of the unintended consequences of measurement. The idea that there's a journey and not just singular episodes. And so we really are not scratching that. Things like, and look at other sources of data, things like wearables, pharmaceutical refill patterns. The interoperability of the experience, right, is more than some of the tools that already exist. And again, this idea of sort of closing the loop. So in summary, consumer experience is really important, and the measurement of experience is an opportunity for innovation. Team?
No, you hit all the points I had. Good job. So strong work. We're going to go to the next group that was looking a little bit more from a research angle. So let's go with the first group there. Who's gonna present for that group? Go for it, Tom.
So
we spent a lot of time talking about a limitation of the caps, which is, I think, something Kamal just talked about and Andy talked about earlier, which is that by definition, it's episodic and it doesn't capture the whole patient journey. And in particular, we talked a lot about how patients come to that episode and their history, and through the lens of health equity. That knowing more about their full journey, even if that's not the main focus of CAPS, is important for understanding and improving health equity. But it's also useful for interpreting the data we get from CAPS, because people's experience up to that point may influence the way they respond to the survey. We talked a lot about the importance of understanding issues of trust, dignity, and shared decision-making. And in terms of reporting the data, the importance of reporting data that's disaggregated and stratified by race and ethnicity. To do that, obviously, you need to have good underlying demographic data. You need to have large samples. And a lot of our discussion, I think, coincided with Robert's presentation. We talked about the importance of patient-provider concordance and the value of having questions that directly ask about, do people feel like they were discriminated against? Do people feel like the way they were treated was fair? We then had a lot of discussion about sort of the impact of these measures and how they can be used to improve quality. Do they effectively discriminate between high and low performing providers? Do they lead low performing providers to want to improve? And can the measures discriminate between low scores that come from a lack of effort versus a lack of resources? Can we identify the pain points where we can actually make improvements? And we finished up, David Atkins was talking about a VA initiative on whole person health that I think touches some of the other discussions we've had today, asking what are the patient's goals and what's important to them, and does the advice that they receive from the provider reflect their own values?
Good. So the next group, which I think was partially remote, all
remote,
all remote,
me.
except for Kathy.
That's right.
Okay. So any additive to what Tom already mentioned?
Yeah, I think the only thing that I'll add, and a lot of what we talked about was talked about in the broader discussion today, but I'll highlight again that patient engagement surveys may not evaluate interactions with other members of the healthcare team. So they may not discriminate there. They may be burdensome for folks with low health literacy. We brought that up a little bit before, so we need to really consider that. And then what pressure does it put on our providers? How does it contribute to provider clinician overall well-being? We brought up some interesting ways that we should think about studying patient consumer engagement, and that is variability across work settings, teams, time of day, weekdays versus weekends. How might they contribute to healthcare policy, payer perspectives, how they might relate to both the engagement of all members of the healthcare team? What does engagement of the team contribute to engagement of the patient consumer? How might patient engagement be affected by care model redesign, virtual care, telehealth, those sorts of things? And then the only other thing that I have not yet heard mentioned that we talked about was the importance of assessing and accounting for tech literacy and device access, and how patient portals may or may not be an appropriate mechanism to get this kind of feedback. And then what's the role of AI as we think about moving forward, was also brought up on our team. And I'll stop there.
Excellent. So those are our comments from our pre-meeting session. Let's jump into let's go to, well, we don't need a slide for this. So we're that's the bulk of the content for the meeting. I want to do a couple things before we adjourn. One, thanks to David Atkins, who left, but a representative of the VA as an ex officio member, but this was his last meeting. in the NAC. So thanks to all of the service that he's provided to AHRQ and to the NAC as an ex officio member. Also thanks for all the folks who contributed today. So Dr. Valdez, as always, Arlene, Henry, Julie, and Rob for all of their presentations and work, and of course all the NAC members both here in person as well as remote for your active participation. And also thanks to we had a very active public today, not just the public comment, but the kind of real-time posting thing. Actually, there was quite a bit of activity on there on the real-time posting. So really nice way to engage, and we may kind of encourage the public to continue that in the future. I'll leave that up to the AHRQ leadership to make that call. Before I have a motion to adjourn, I'd like the Dr. Bajaj haiku for the day.
So my brain processes things and haikus, and sometimes I don't actually follow the format, but patient experience is crucial and not moments, but journey as team.
Thank you, week. Yeah,
It's my quarterly tradition.
yes, it is. We will have haiku t-shirts coming out soon.
And the haiku cat.
Right, exactly. The next NAC meeting, so that we can all prepare to all write haikus at the end of it, is November 16th. It's planned in person. So make your plans appropriately. With that, I will.
Before you do that,
sorry.
Let me say thank you to Jamie and to the staff for organizing and arranging things. And of course, thank you to our great chairman who keeps us on time, moves the agenda ahead, and gives us little time to eat.
Somebody call, thank you. Thanks, Bob. So now I will entertain a motion to adjourn. Moved and seconded with no objections. We are adjourned. Thank you all.
Be well.